Welcome you all to this webinar. Greetings from e-NEETI, Nurses' Efforts to Eliminate TB in India. It's an innovative telementoring program designed to create virtual learners by bringing together healthcare providers, especially nurses, as presenters and subject matter experts, using video conference technology, brief lecture presentation, and case-based learning. As World TB Day is on 24th March and the theme is Yes, we can end TB. Commit, invest and deliver. Aligned with World TB Day on 24th, we are conducting this webinar today on the topic Basics of Airborne Infection Prevention and Control. The theme emphasizes the importance of global collaboration, strategic investment, and effective implementation of interventions to combat TB. And by embracing this theme, World TB Day 2025 aims to inspire hope, urgency, and accountability in the global efforts to eliminate TB. WHO NTB strategy aims to reduce TB by 90% by 2035. Together, we can eliminate TB and ensure a healthier future for all. Well, it's great to see so many enthusiastic participants joining us from different locations. Participants are mainly clinical nurses, healthcare workers, paramedical staffs, laboratory technicians. Welcome you all. Let me introduce myself. I am Shima John, Senior Nursing Officer from NITRD and moderator for today's e-NEETI and webinar. We are honored to have distinguished panel of speakers and experts with us today. Their knowledge and experience will provide us deep insight on airborne infection control and prevention. Welcome you all. We are truly grateful to have our chief guest, Dr. Urvashi Singh, DDG TB India. I think there's some technical issues. She might join later. We are truly grateful. We have here with us today expert Dr. Paul Jensen. Dr. Paul Jensen, independent consultant in engineering and airborne infection control prevention. A warm welcome, sir.
Thank you.
Ma'am, Dr. Bhalla ma'am, the medical director of our institute, NITRD. We welcome you, ma'am. To my right is Dr. Anita Rani Kansal, nursing superintendent of NITRD. Welcome you, ma'am. To my extreme right is Dr. Singla ma'am. She is DTO officer from our institute. Welcome you, ma'am, too. Before moving to the topics, let me request Dr. Suanand Sahu, Deputy Executive Director, Stop TB Partnership, Geneva, Switzerland, to deliver his opening remarks for this webinar. Sir is a strong advocate for innovations in prevention and case universal and equitable access and people-focused work. We welcome you, sir. So, can you hear me?
Yes, please. Can you hear me?
Yes, sir. You're audible.
Great. Thank you. And it's a pleasure to be here. First of all, a very good morning. It is 6:30 a.m. in Geneva. So it's a pleasure to be here. Greetings from the Stop TB Partnership. And next Monday, as you know, 24th of March every year is World TB Day. It's a day that reminds us every year, the same day, that there is urgent need to accelerate our efforts to ending TB. Each year, Stop TB Partnership, in consultation with partners, sets the theme for the World TB Day. This year's theme, as you know, is Yes, we can end TB, and three important words: commit, invest, deliver. Over the last few years, as you may have noticed, Yes, we can end TB has become a slogan for global TB response, motivating people and creating a movement and passion to end TB. So that is the theme also reminds us that to end TB, we need commitments, bold commitments, not small ones. We need investments in terms of funds, but also in terms of everybody's time. There are different stakeholders that can end TB. And we need to deliver on our promises and commitments. So these three words are very important. As we focus today on airborne infection prevention, we must recognize that TB continues to be the world's deadliest infectious disease. It is unacceptable that a disease that can be prevented, diagnosed, treated, and cured is still killing 1.25 million people. That was the data for 2023 published by WHO. We know that TB spreads through the air, making airborne infection control measures a critical frontline defense against the disease. We cannot end TB just focusing on diagnosis and treatment. We need to prevent TB by stopping airborne transmission from one person to other. To commit to end TB, we must prioritize infection prevention. To invest, we need increased funding for airborne infection prevention and control practices. And to deliver, we must ensure that prevention strategies are effectively implemented in healthcare settings, workplaces, and other congregate settings. All of us went through the COVID pandemic, and the next big pandemic, whenever it happens, it's very likely to be an airborne infection to cause that kind of a havoc. Airborne infection prevention in TB will prepare the world, prepare us better to face the next pandemic. Many of you are healthcare workers, as just announced. I am also a healthcare worker. Very happy to see the institute there. I have visited this institute several times in my work. In many years ago, I was in India. But when I worked there, nobody tested me for TB infection. But when I came to Geneva, I got tested for TB infection, and my test was positive. Fortunately, my infection did not progress into active disease. But my message to all of you is to ensure that your health facility has adequate systems for airborne infection prevention to protect you and also to protect others. Today's meeting is a crucial opportunity to share knowledge, discuss challenges, and explore innovative approaches to prevent airborne TB transmission. By working together, healthcare workers, researchers, policymakers, and community leaders, we can protect lives, strengthen health systems, and move closer to a TB-free world. Let us use this occasion not only to reflect on our progress, but also to renew our commitment to ending TB. With strong policies, adequate resources, and unwavering determination, we can turn our vision into reality. Thank you, and I look forward to today's discussion. Thank you.
I appreciate your time. And now I just want to add something more. This webinar is conducted in collaboration with our esteemed partners, whose expertise and support have been instrumental in making this webinar possible. It's in collaboration with Core Working Group of ETTI powering Airborne IPC, Stop TB. It's a working group of Stop TB partnership aimed to support the global fight against TB and other airborne infections by promoting development and implementation of feasible measures able to prevent and control airborne infection transmission. Our institute, NITRD, Indira Gandhi Medical College and Hospital, Nagpur, and Stop TB partnership, e-NEETI, of course. Now, moving forward with the program, I request all participants to please keep their microphones muted unless you have to speak. So there is no distractive noises. Please keep your microphones muted. Feel free to use chat box for questions and comments later on. And there's a main thing, join separately and not in groups to avail certificate. As if you don't join separately, you won't be able to get your certificates. Please, I kindly request you, all of you, to join separately through your mobile or your email. And please don't do multitasking. Now, moving on, it's my pleasure to introduce Dr. Grigory Volchenkov. Dr. Grigory Volchenkov, can you hear me?
Yes.
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir. Dr. Grigory Volchenkov, Chair, ETTI, TB and Airborne Infection Prevention Control Consultant, Vladimir, Russia. Dr. Volchenkov successfully implemented comprehensive TB IPC programs in TB control services of Vladimir region in cooperation with WHO, CDC and Eagleson Institute, Mane, USA. Sir is currently an independent and airborne IPC consultant and will brief us about ETTI powering airborne IPC. Sir, we welcome you.
Thank you very much. Dear participants, dear organizers and the faculty of this important webinar organized on occasion of World TB Day, I would like to greet you on behalf of ETTI and TB Transmission Initiative, powering airborne IPC. We are working group of Stop TB Partnership, and we are a multidisciplinary group of experts, implementers, scientists, researchers, practitioners who are involved in TB infection prevention and control. The mission of our group is to advocate for and lead operationalization of policies and expansion of the evidence-based through research, education, training, and scaling up effective implementation of TB and airborne infection prevention and control. Our working group is supporting the global fight against TB and other airborne infections by promoting development and implementation of feasible measures able to prevent and control the airborne infection transmission. I am glad to tell you that several members of ETTI are involved in the organization and conducting of this webinar. And Paul Jensen, our leading expert, is in India now these days. I hope he will tell the purpose of his important visit with the technical assistance. Also, I would like to thank three individuals who are members of ETTI, namely Anita Rani Kanzal, Dr. Gyan Shankar Mishra, and Dr. Manpreet Bhala, who will be presenting and actually who organized this webinar. I would like to underline the importance what was just said by Dr. Sahu, that TB-IPC is extremely important in reducing the professional occupational risk for healthcare workers, in reducing TB transmission in our facilities. And we can make our facilities much safer. And we have to learn the lessons of the former Soviet Union countries, Russia and others, who actually produce lots of drug-resistant TB because of ignoring basic principles of feasible IPC measures which can prevent airborne transmission. It's also important to mention that if we are prepared to prevent TB transmission, we are very much prepared for airborne transmission in terms of pandemic preparedness, like Dr. Sahu just said. Back to ETTI, I would like to introduce the website and our working group, and you can see the link and QR code here, and you can find a lot of useful resources in many languages, including English, Spanish, French, Chinese, Russian, and you can find the materials of the conferences, lectures, presentations, important publication, guidance. You can find the newsletters from our working group. And there are several actually very useful, very brief and useful documents called information sheets dedicated to implementation of different components of airborne TB IPC. Just last week, we updated it with a new short guide on how to conduct IPC assessment of the facility developed by a Peruvian architect and IPC expert Isabel Ochoa. So I would like you also to consider joining our team to be e-TTI members and to subscribe to the newsletter we publish on quarterly basis. And you can find lots of useful information of the most recent publication on this topic, and find out about activities and some useful practical information about implementation measures. So welcome to join e-TTI, and I would like to thank again organizers, National TB Elimination Program of India, and good luck to the coming webinar. Thank you so much. Okay.
Sir, a heartfelt thank you to the for you to taking time to brief us on e-TTI and its clear understanding of its importance. Thank you, sir. And sir, we'll surely subscribe to your newsletter. We nurses will definitely do, sir. Now we would move to the topics. Our first speaker for today's webinar is extreme to my right, Dr. Anita Rani Kansal, Nursing Superintendent and CNE Chairperson, NITRD Delhi. Dr. Anita has been a master trainer for training of nurses in TB by ICN. She has been recognized by ICN TB MDR TB project as a leading light in recognition of her outstanding contribution to the care of people affected by TB, conferred by ICN Geneva, Switzerland. Ma'am's topic for today is Basics of IPC, Role of Administrative Control in Airborne IPC. Welcome you, ma'am.
Thank you. Okay. Thank you, Sheba.
On to you.
Thank you, everybody. So today's webinar is related to the TB day, and we as a e-TTI members also working on the airborne infection prevention and control. So this is related to all three speakers will be speaking on the infection prevention and control. So just to say that what is airborne disease, because any disease that is caused by the pathogen, whether it's bacteria or virus, that can be transmitted through the air. So that will be airborne disease. So diseases can be TB, COVID-19, whooping cough, SARS, influenza, diphtheria. There are so many diseases that are being transmitted by the air. But we are mainly today concentrating on TB. Why? Because the TB is such a disease that we are not able to take up from centuries. It's still a major killer, which is preventable. As Dr. Sahu said, a preventable disease is killing so many people even at present. So we are mainly concentrating on TB prevention. So TB is infectious disease caused by, everybody knows this, by Mycobacterium tuberculosis, and the transmission occurs through the aerosols by the cough, sneeze, or the speaking. And why we are focusing on this disease? Because India has a high burden of disease, and the government has a plan to achieve sustainable development goals to end TB by 2025. And this is just a little effort by nurses that we are doing some effort to contribute in this elimination. And most important is it is a preventable disease. We can prevent it. So risk of this is just why we are understanding this, because the infection prevention will be the basis of infection prevention will be this slide. That where the source is, from where that bacteria is coming, how it is being transmitted, who is receiving it, and how it is converting into the disease. If we understand this transmission cycle, and then we will be able to have a better control. So these are just some of the factors that how the transmission takes place, like the patient-related factors. This is just a corridor of our hospital. We have taken picture of this. So many people will be present at the same time, and many of them are the TB patients, and some are non-TB patients are also there in this group. So cuff etiquettes, that's very important. If the person is using a very good cuff etiquettes, covering their mouth while sneezing or coughing, then the transmission will be less. Then sputum AFB positivity. Uh, if the patient is AFB positive, then it will transmit more. Then the treatment, those who are on the treatment for at least 2 weeks, they are less transmissible. So it's very important that we detect the patients and put it on treatment. Then the lifestyle, like the ventilation, is very important. In India, many of the people, they do not have the windows or the ventilation facility in their homes. So that is also one factor. So like over environmental factors, we have the overcrowding, duration of exposures. Here the duration of exposure means that's why the healthcare people are important, because they spend a lot of time with the TB patients. Then inadequate ventilation.
Presentation after this first presentation.
Inadequate ventilation, and then the recirculation of air containing the infectious droplet nuclei. Recirculation means like if we see this room, you just check, we do not have, if you can see this room, we do not have any window or any circulation. And this is one of the monitor, this is the carbon dioxide monitor, which is checking that what is. So here the reading is
Camera up left.
okay. Yeah. So this is the reading. So we can see that we do not have any ventilation, and after this seminar, we would like to see that what is the reading on this. This is measuring the carbon dioxide in our room. So we will see after the seminar what is the reading. You can note down. You can write in the comment what is the reading at this. It is 1473 at present. So the host-related factors means who will be getting the TB. That's those who are immunosuppressive, like the HIV-infected patients, diabetes, patients on immunosuppressive drugs, long-term steroids, and the healthcare workers. So these are the host-related factors. Now, what is ventilation? Because हम लोगों ने अभी यही देखा कि किस वजह से TB और कैसे फैलता है. Now, how we can take care of the infection control? What is ventilation? That is movement of air, which we do not have at present in this room. And pushing and pulling of the particles, whatever I'm speaking, if I'm shedding anything, that will be here in the room only. So, and ventilation should be in the controlled manner also. That is also important. So ये स्लाइड बहुत लोगों ने देखी होगी. इसमें क्या है कि जितने बड़ा ड्रॉपलेट होएगा, जिसमें म्यूकस होता है, which we can see from coming anybody's mouth, so that will fall fast. The small, जितना छोटा ड्रॉपलेट होगा, that will hang around. वो एयर में घूमता रहेगा, फिर वो एयर में घूम के इधर उधर, it can be inhaled by another person. So basically it matters कि साइज जो भी कोई ड्रॉपलेट है उसका साइज क्या है, वो कितनी देर में एयर में रह सकता है, दैट इज इम्पोर्टेंट टू सी. और इन्हीं चीजों पे डिपेंड करता है कि हमारी जो इन्फेक्शन प्रिवेंशन है वो कैसे होएगी. लाइक या तो हम डाइल्यूशन कर दें हवा की, यहाँ पे बहुत सारी एयर चेंज हो जाए, या फिर ये है कि भी उस बैक्टीरिया को, जो उस वायरस को हम किसी और चीज से वी कैन किल इट. So that will be seen in the environmental controls that will be taken by Dr. Gyan Shankar. So the large droplets, they will be trapped in the upper airway trapping. Upper airway trapping है, हमारे nose में बाल होते हैं, mucus होता है, that will be trapped there. But the droplet nuclei, which are from the 1 to 5 microns, they can reach directly to the alveoli. That's why the TB है हमारा वो lower respiratory infection है, because वो directly alveoli तक पहुंच जाता है. दिस इज जस्ट कि साइज जो बाहर हमारा स्पीकिंग से या कफिंग से जो साइज आता है वो कैसे मैटर करता है. अगर वो ड्रॉपलेट है और 5 नैनोमीटर से बड़ा है, और अगर वो ड्रॉपलेट न्यूक्लाई है और 5 नैनोमीटर से छोटा है, तो ये मैटर करता है कि वो कितनी देर में नीचे फॉल हो जाएगा. अगर नीचे जमीन पे फॉल हो जाता है, देन इट विल बी लाइक वी विल बी मोपिंग द फ्लोर विद डिसइंफेक्टेंट, देन इट कैन बी किल्ड. सो दिस स्लाइड इज जस्ट शोइंग द ड्रॉपलेट साइज and time taken to fall 1 meter. So you just see कि अगर कोई 1 नैनोमीटर साइज का ड्रॉपलेट है, उसको करीबन 8 घंटे लग जाएंगे कि वो नीचे गिरे. 8 घंटे तक वो हवा में ही घूमता रहेगा. So it can infect the persons. अगर वो 5 नैनोमीटर है तो उसको 21 मिनट लगेंगे 1 मीटर फॉल करने के लिए. और अगर वो 10 नैनोमीटर है तो उसको 5-6 मिनट में वो नीचे गिर जाएगा, और अगर वो 50 नैनोमीटर है तो वो 13 सेकंड में। इसमें हम ये देख पा रहे हैं दैट द स्मॉलर पार्टिकल्स, जैसे गर्मियों में क्या होता है कि जो म्यूकस या पेशेंट से ऐसे निकल के बाहर आया वो डिहाइड्रेट हो जाता है, तो डिहाइड्रेट होके वो स्मॉलर एंड स्मॉलर पार्टिकल्स बन जाते हैं, तो इन्फेक्टिविटी रेट बढ़ जाता है। हमारे यहाँ पे एक छोटी सी रिसर्च स्टडी करी थी वेरिएशंस की, कि सीजन में क्या वेरिएशन होती है, तो उसमें ये देखा गया था दैट those infectivity is more in the summers than the winters. So effective ventilation फिर क्या है कि effective ventilation क्या है? ये air changes per hour, ये air changes per hour what it is, होता क्या है? इसका मतलब ये है कि इस कमरे की जितनी भी एयर है वो 1 घंटे में अगर 6 बार बदली जाती है तो दैट्स अ गुड साइन कि उसमें अच्छी वेंटिलेशन है। और अगर जैसे हाई रिस्क सेटिंग्स हैं, अगर वो टीबी वार्ड्स हैं, एमडीआर वार्ड्स हैं, तो वहां पे दिस शुड बी मिनिमम 12, वो 12 होनी चाहिए। 12 का मतलब क्या है कि 12 बार पूरी की पूरी हवा 1 घंटे में उस कमरे में से बदली जानी चाहिए।
Hi, Gogan.
So,
No, you go ahead. No, I was saying that first of all, it's great that you joined the e-NEETI.
दिस इज वेरी इंपॉर्टेंट कि हवा कितनी बार बदली जा रही है। फिर दूसरी बात है कि कंट्रोल ऑफ फ्लो, हवा बदली तो जा रही है, किस तरफ जा रही है, दैट इज वेरी इंपॉर्टेंट। लाइक हमारे एमडीआर वार्ड में जिस तरफ पेशेंट का सिर होता है, जिस तरफ पेशेंट कफ करता है, वहां पे एक एग्जॉस्ट फैन लगा हुआ है, एक पुलिंग लगा हुआ है, ताकि वहीं से एयर, वो जो एयर जिसमें सबसे ज्यादा बैक्टीरिया है वो खींच के बाहर की तरफ हम उसे फेंक सकें। सो दैट इज कंट्रोल ऑफ फ्लो इज वेरी इंपॉर्टेंट। खाली वेंटिलेशन इंपॉर्टेंट नहीं है कि हवा किधर से किधर जाए, बट दैट फ्लो इज ऑल्सो इंपॉर्टेंट कि हवा किधर से किधर जा रही है, स्पेशली इन द हेल्थ केयर सेटिंग और इन द वार्ड्स। यहाँ पे सिस्टर्स का रूम कहाँ पे है और पेशेंट कहाँ पे है, दिस इज ऑल्सो इंपॉर्टेंट। नेक्स्ट, ये थोड़ा सा ये दिखाया हुआ है कि अगर कोई बैक्टीरिया, वायरस या एयर में कुछ भी है तो उसको कितनी देर में वो बाहर हम निकाल सकते हैं। वो यही है कि जितना ज्यादा एसीएच होगा उतनी जल्दी वो बैक्टीरिया, वायरस या जो भी पार्टिकल्स हैं, आजकल पोल्यूशन है, पीपीएम भी है, तो वो सब भी बाहर उतनी जल्दी, जितनी एयर चेंज होएगी उतना ज्यादा जल्दी निकल सकता है। नेक्स्ट, ये जो हम बात कर रहे थे डायरेक्शन की, क्योंकि डायरेक्शन खाली वेंटिलेशन से नहीं होगा, डायरेक्शन इज इंपॉर्टेंट। आपको कहीं जाना है, आप कितनी भी स्पीड से गाड़ी भगा लो, अगर उसकी डायरेक्शन ही सही नहीं है तो आप कहीं और पहुंच जाओगे। इन द सेम वे, अगर हमने वेंटिलेशन बहुत अच्छी रख ली पर हमने ये वी हैवंट पुट कंसंट्रेशन ऑन कि किधर से किधर हवा जा रही है, दैट इज वेरी इंपॉर्टेंट। लाइक इन द फर्स्ट लिस्टिंग हम लोग ये देख रहे हैं कि हेल्थ HCW इज हेल्थ केयर वर्कर, फिर पेशेंट किधर है और विंड किस तरफ से किस तरफ जा रही है। इन द फर्स्ट पिक्चर दैट सीम्स अ वेरी गुड कि हेल्थ केयर वर्कर से हवा होके फिर पेशेंट, इफ ही इज कफिंग, ही हैज अ बैक्टीरिया, देन इट इज गोइंग आउट। So another in the second is bad, that is the air is going from the patient to the healthcare worker and then it is going out. So everybody, ये इस वाले वेबिनार का पर्पस ही सिर्फ ये है कि हर कोई अपनी आसपास, अपने वार्ड में, अपने रूम में, अपने क्लिनिक में ये देखना शुरू करे कि वहां पे हवा है और वो कैसे मूव कर रही है, वेदर इन विच डायरेक्शन इट इज गोइंग, एडिक्वेट है कि नहीं है। अगर आप लोग सिर्फ इतना भी देखना शुरू कर दोगे तो मेरा आज का ये पर्पस सॉल्व हो जाएगा। हमें कोई बहुत हाई रॉकेट साइंस नहीं पढ़ना, जस्ट वी हैव टू सी वेदर व्हाट वी आर इनहेलिंग, वो किधर से आ रही है, किधर से जा रही है। दैट इज वेरी इंपॉर्टेंट। इफ यू विल स्टार्ट लुकिंग फॉर दिस, आई थिंक दैट विल बी वेरी वेरी गुड। फिर कई बार होता है कि जैसे ओपीडीज में सेटिंग ऐसे है कि डॉक्टर इस तरफ बैठा है, पेशेंट इस तरफ बैठा है, आप उसको कुछ भी, यू कांट डू इट, आप उसे कुछ भी कर नहीं सकते। तो उसमें देन यू कैन मेक सम गुड कॉम्प्रोमाइज दैट एट द वन साइड, इन द पिक्चर 3 यू कैन सी एट द वन साइड द हेल्थ केयर वर्कर इज देयर एंड द अदर साइड पेशेंट इज देयर एंड सम वे, सो इट हैज टू बी सीन एंड यू पीपल शुड बी अवेयर ऑफ दिस। नेक्स्ट, this is again that is showing that this is in the left picture, that is showing at the head end of the side there is a exhaust fan attached, and that we can see that the how air is moving, that we have to see. Next, ये स्लाइड दैट इज शोइंग कि जितनी ज्यादा पार्टीशंस होंगी उतना एयर का मूवमेंट कम होता जाएगा, उतनी आपको कम वेंटिलेशन वाली एयर मिलती जाएगी। हम देख सकते हैं कि यहाँ पे ऑलरेडी पार्टीशन है, नेक्स्ट जोन में वो जो स्टेगनेंट एयर है दैट विल बी देयर। नेक्स्ट दिस विल बी कवर्ड बाय डॉक्टर ज्ञान मिश्रा। नेक्स्ट ये हम आपको हेल्थ केयर वर्कर्स को क्यों सेंसिटाइज करना चाह रहे हैं, ये उसका रीजन ये है कि ये बहुत सारी रिसर्च स्टडी ने प्रूव कर दिया है कि एनी हेल्थ केयर वर्कर्स दोज हु आर वर्किंग इन टीबी वार्ड्स और हेल्थ केयर फैसिलिटीज विद टीबी पेशेंट्स, they always have a more risk of developing TB as compared to the general population. ये इस वजह से ये बहुत सारी रिसर्च स्टडीज ऑलरेडी हो चुकी हैं जो ये प्रूव करती हैं। दैट्स व्हाई वी हैव टेकन द हेल्थ केयर वर्कर्स टू सेंसिटाइज दिस टॉपिक। ये भी वही है कि इंसिडेंट्स बता रहे हैं, इसमें मधुकर पाए, ही हैज डन लॉट ऑफ वर्क ऑन दिस हेल्थ केयर वर्कर्स ट्रांसमिशन ऑन इंसिडेंट्स ऑफ टीबी इन्फेक्शन। नेक्स्ट अब ये है कि भी जो हेल्थ केयर वर्कर्स हैं उनमें टीबी तो ज्यादा हो ही रहा है, वो तो प्रूवन हो ही गया। अब ये देखा गया कि कौन सी जगह पे जो है वो टीबी सबसे ज्यादा ओपीडी में, आईपीडी में, इमरजेंसी रूम में, लैबोरेटरीज में, ब्रोंकोस्कोपीज में कहाँ सबसे ज्यादा होता है। तो ये देखा गया था यूजुअली जो ओपीडीज है वहां पे टीबी का जो रिस्क रहता है वो ज्यादा रहता है, बिकॉज वहां पे अनडायग्नोज्ड केसेस आते हैं, अभी वो ट्रीटमेंट पे शुरू नहीं हुए हैं, तो दे आर मोर इन्फेक्शियस। यूजुअली वार्ड्स में स्पुटम पॉजिटिव केसेस होते हैं, बट एटलीस्ट दे हैव बीन स्टार्टेड, उनका कोई डायग्नोस बन गया है और वो एटलीस्ट ट्रीटमेंट पे हैं। और जो लेबोरेटरीज है वो आप देख सकते हो कि ऑलमोस्ट 80% जो है वो सबसे ज्यादा लेबोरेटरीज में क्यों है, क्योंकि वो तो बैक्टीरिया निकाल के फिर देखते हैं उसे, फिर उसे उसमें लगाते हैं स्लाइड में, वो तो पूरा बिकॉज दे आर डीलिंग विद डायरेक्टली विद बैक्टीरिया विद स्पूटम सैंपल्स, तो वो सबसे ज्यादा जो है वो लैब्स और लेबोरेटरी टेक्नीशियंस को रिस्क रहता है इसमें। इसीलिए आज के इस सेशन में डॉक्टर मनप्रीत भल्ला जो लास्ट में वो पूरा लैब्स में कैसे एयरबोर्न इन्फेक्शन कंट्रोल करना है और सैंपल्स को कैसे हैंडल करना है, दैट शी विल बी डीलिंग विद इट। नेक्स्ट ये डॉक्टर वो डील करेंगे, ये भी छोड़ हाँ, ये लास्ट बैक ये एक छोटी सी हम लोगों ने ना ऐसे एक स्टडी करी थी हमारे हॉस्पिटल में, ये नर्सेज ने करी थी, मैंने और एक हमारी स्टाफ नर्स थी, नाउ शी हैज लेफ्ट, शी हैज गॉन टू यूके। हम लोगों ने ये देखा कि ACH जो एयर चेंजेस है उनको कैसे थोड़ा बेटर कर सकता है। तो एक सिंपल चीज थी कि जो जितनी भी वो मॉस्किटो नेट जाली लगी हुई थी उसको थोड़ा क्लीन किया, और एग्जॉस्ट फैन को क्लीन करने से ऑलमोस्ट डबल एयर चेंजेस हो गए थे। ये छोटा सा ऐसे ही हम लोगों ने लर्निंग के लिए, जब हमने नया नया सीखा था एयरबॉर्न इन्फेक्शन कंट्रोल, तो एक छोटा सा ये प्रोजेक्ट करा था जो हमने अपनी नेटकॉन जो नेशनल कॉन्फ्रेंस है उसमें पोस्टर ये प्रेजेंट भी करा था। तो अब इन सबको जो एयरबॉर्न इन्फेक्शन कंट्रोल है इसको बहुत बार देख समझ के व्हाट दे हैव डन कि इसको कैसे इंप्लीमेंट कर सकते हैं। सो मेनली ये तीन जो थे, इट कैन बी डन बाय एडमिनिस्ट्रेटिव कंट्रोल्स, एनवायरमेंटल कंट्रोल्स एंड रेस्पिरेटरी प्रोटेक्शन कंट्रोल्स। सो आई विल बी टॉकिंग अबाउट द एडमिनिस्ट्रेटिव कंट्रोल्स, डॉक्टर ज्ञान मिश्रा विल बी टॉकिंग अबाउट द एनवायरमेंटल कंट्रोल्स, एंड मैडम मनप्रीत भल्ला विल बी टॉकिंग अबाउट द रेस्पिरेटरी कंट्रोल्स। So this is the administrative controls. Administrative control होते क्या है? This is the first priority. This will reduce the exposure. Environmental control is the second priority, and the respiratory control is the third priority. Why? That I'll explain in the next slide. Administrative control वो वाले controls हैं जो एडमिनिस्ट्रेशन, जो किसी इंस्टीट्यूशन की हेड या फिर CTD जैसे कोई प्रोग्राम है उनके हेड बनाते हैं कि हमें क्या क्या पॉलिसीज डेवलप करनी है जिससे हम अपने हेल्थ केयर वर्कर्स को या पेशेंट्स को या रिश्तेदारों को जो विजिट करते हैं उनको हाउ वी कैन प्रोटेक्ट देम। सो दिस इज वेरी 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 इफेक्टिव, बिकॉज ये बहुत बड़े लेवल पे होती हैं और इट हैज अ गुड आउटकम। नेक्स्ट, this is likely to have the greatest impact. This serves as the first line of defense for preventing spread of TB in healthcare setting, and it can be implemented at all levels of healthcare, whether it's primary, secondary, or tertiary. It can be done at the both inpatient and the outpatient areas. ये एक सिनेरियो है किसी भी गवर्नमेंट हॉस्पिटल का इन इंडिया. व्हाट डज दिस शो? ये हमारे हॉस्पिटल में भी होता है. एवरीवेयर दिस इज लाइक. व्हाट डू वी लर्न फ्रॉम दिस स्लाइड? नेक्स्ट. कि हम इसको कैसे कम कर सकते हैं. हम अपॉइंटमेंट इन सिस्टम कर सकते हैं, जैसे प्राइवेट हॉस्पिटल्स है, हर 10 मिनट एक पेशेंट को देते हैं, सो दैट उसी टाइम पे उतने लोग वहां पे नहीं आएंगे. फिर हम लोग क्या कर सकते हैं? स्क्रीनिंग फॉर कफ. कि बाहरी जो कोई स्लिप दे रहा है, जो कोई बाहर बाहर जो भी कोई वो गार्ड बैठा हुआ है, वो पूछे कि जिसको खांसी है वो इधर हो जाए, या फिर वो टीबी का पर्चा देख ले, जिसका टीबी है उसको एक तरफ कर ले. सेग्रीगेशन एंड ऑन अर्ली कंसल्टेशन. जैसे बाकी जनरल हॉस्पिटल्स है, लाइक सफदरजंग है, जो बड़े हॉस्पिटल्स हैं, वहां पे वो कफ वाले पेशेंट्स को बिल्कुल एक बार अलग करके उन्हें अलग ट्रैक पे लेके और उन्हें अलग कंसल्टेशन करवा सकते हैं. देन वेटिंग एरिया है, जो वहां पे कुछ ना कुछ इन्फेक्शन कंट्रोल मेजर्स होने चाहिए, प्रॉपर वेंटिलेशन होनी चाहिए, मास्क प्रोविजन कर सकते हैं, और अनाउंसमेंट्स कर सकते हैं हम लोग दैट दे शुड कवर देयर फेस व्हाइल कफिंग. नेक्स्ट. अब आता क्या है एडमिनिस्ट्रेटिव कंट्रोल मेजर्स में? हम क्या क्या कर सकते हैं? डेवलपिंग इम्प्लीमेंटिंग अ रिटल टीबी इन्फेक्शन कंट्रोल प्लान. अभी सारे हॉस्पिटल्स में क्या है, सब लोग दे विल टॉक अबाउट वेंटिकुलर एसोसिएटेड निमोनिया कितना हो गया, सर्जरी के बाद एसएसआई कितना हो गया, बट नोबडी इज टॉकिंग अबाउट कि आपके आपके यूनिट में एयरबोर्न इन्फेक्शन कंट्रोल कैसा है, वहां कोई एग्जॉस्ट फैन है भी कि नहीं है, वहां पे एयर कहीं से हम चेंज कर भी सकते हैं, बट नोबडी इज टॉकिंग अबाउट दैट. So all the infection control is related to pneumonia, in ICU, VAP, central line से कितने infection हो गए, that every hospital is calculating, but they are not giving attention to the airborne infection control. Then ensuring an availability of laboratory processing, testing and reporting of results, ensure proper cleaning and sterilization and disinfection, yes. Educating and training healthcare workers, then calculating, monitoring ACH, air handling units and HEPA filters, patient education, sputum collection. So on all this, administration has to make some policies if we want to have a good airborne infection control. Next. Next one. So this is again about that how we can put the administrative control in the OPD. We can screen, educate, separate, and provide services, and investigate for TB or referred. Next. So this is like screening, that as I have already explained, that on the registration we can have the screening counter and we can have advertisements. Next. These red are showing the coughing patients. These can be fast tracked. So we need to put posters everywhere so that cover your mouth, because these do impact. These IECs or these posters do have an impact on patients or the relatives. Next. These are again like, so sputum collection area should be at the separate, it should be away from the main hospital or the main building. These are special, where we have to take the special care, like the bronchoscopy, suctioning, because these are sputum induction, and where we have a lot of aerosols generations. Segregation, that all the HIV and the TB patients should be kept separate. Next. So what some practical implementation we have done at the NITRD once we learn about the airborne infection control at the time of when Dr. Rohit Sareen was here. So we have done, I'll show you that we just had that infection control committee which were looking after the airborne infection control. Then we had a separate TB and non-TB wards, and MDR wards were also separated. This is the picture of one of the MDR ward where we have a negative pressure also, and sister is looking at the camera where she can see the patients with this camera. So we have a policy of staff rotation in TB and non-TB wards. Then policy of staff immunization and regular screening for TB. Annual screening of all the staff is being done at NITRD. Then regular training. This is one picture of the training of the nurses. Then action taken, see, rearrangement of furniture. We saw, because those people who are working at the ground level, they can give so many ideas. ये सारे ideas हमारी nurses ने दिए कि वहां पे एक बहुत बड़ी window तो है, but उस window के आगे हमने एक अलमीरा रखी हुई है, वो अलमीरा हटा दी so that the better ventilation can be there. So at on your own place, you can have a very good evaluation of your place, that how you can improve the air ventilation there. Changing of wire mesh, regular cleaning of the small ventilators, providing PPP to the staff and exhaust systems. This all can be done. So this is a sputum collection area. Previously we had this hexagonal structure. एक ऐसे बंद structure था जिसमें हर patient sputum के लिए जाता था, sputum collect करके sample छोड़ता था. फिर धीरे धीरे ये पहले ये सोचा गया था कि भी इसमें एक UV lamp लगा हुआ है, that will take care. But ultimately it was seen कि that was not effective. Or rather it was creating more infection. तो फिर धीरे धीरे जैसे जैसे हमारी learning और होती गई, जो भी whatever new was coming, so an open sputum collection chamber away from the crowd that was made. So this is just our OPD picture where we have a shaft in center of this. This is a good way to have a ventilation. This is at the all four sides there are rooms, and in the center we have this shaft. This is UV lights to take care of infection. So UV lights भी कैसे लगेगी? अगर एडमिनिस्ट्रेशन कोई इसमें एक्शन लेगा that we need these UV lights और इसका कोई बेटर हो सकता है और कहाँ लगा सकते हैं. So these are all the administrative measures. Then provision of mask to the OPD and the IPD patients. ये भी हम लोगों ने शुरू करा था many years back, डॉक्टर सरीन के टाइम में, कि हर पेशेंट को जो भी कोई ओपीडी में आ रहा है उसको एक मास्क हम लोग वहीं से दे रहे थे. और जितने आईपीडी वाले पेशेंट्स थे उनको हम लोग लिनन मास्क दे रहे थे. एक बार लिनन मास्क दे देते थे, वो डेली वॉश करके उसे पहनते थे एंड दे यूज्ड टू टेक विद देयर होम. तो हम लोगों ने एक टेलर सिर्फ इसीलिए रखा हुआ है कि वो उन मास्क को बनाता है और फिर बना के हम लोग हर वार्ड में हर पेशेंट को देते हैं. So cuff talks, we have a health education officer. वो ये सब इन चीजों का ध्यान रखते हैं that they keep on teaching the patients in the wards. Then regular fumigation of the special units like dressing room, minor OT, ICU and OT, and yoga facility for the staff and the patients for better immunity and well-being. So take home message क्या है? हमें कोई बहुत वो नहीं देखना, जस्ट हमें ये देखना है कि हमारे आसपास की हवा कैसी है. और जब आप कहीं भी एंटर करते हो तो एटलीस्ट आप ये देखना शुरू कर दो कि हवा किधर से आ रही है और किधर से जा रही है. जब से हमें इंटरनेशनल काउंसिल ऑफ नर्सिंग ने ये एयरबॉर्न इन्फेक्शन पढ़ाया था, उसके बाद से मेरी हैबिट ही बन गई है. मैं असेसमेंट करने के लिए आई गो टू वेरियस हेल्थ फैसिलिटीज. सबसे पहले जाके यही देखती हूँ कि यहाँ पे विंडो कहाँ पे है, हवा किधर से आ रही है, किधर बैठा कौन है. सो I think that should be your habit. अगर ये ऐसा कुछ आप लोग डेली चेक करना शुरू कर दोगे तो that will be just purpose of my this webinar. Next. So the next speakers will talk about environmental control, respiratory control, and IPC measures in laboratories. Thanks, Karna, for the questions.
Thank you, ma'am. Thank you, ma'am, for strengthening our knowledge and approach in this area. Thank you once again for your invaluable contribution. I can see that Dr. Urvashi ma'am, DDTTB, has joined us. I'm like, we are truly honored to have with us today our chief guest, Dr. Urvashi Singh, DDG TB India. Ma'am, your vision and your commitment continue to motivate healthcare professionals, especially nurses, to work tirelessly towards the goal of TB-free India. Ma'am, I request you to address the participants and share insights and words of encouragement. Dr. Urvashi ma'am, can you hear me?
She'll come in 10 minutes.
Maybe she'll join in 10 minutes. Moving on to the next speaker, we have online with us Dr. Gyan Shankar Mishra, Associate Professor, Respiratory Medicine, Indira Gandhi Government Medical College, Nagpur. Sir is going to speak on the topic TB in healthcare workers and role of environmental control measures in airborne IPC. We welcome you, sir. Can you hear us?
Sure. Thank you.
Welcome, sir.
So can I start?
Yes, sir.
So thank you. The nice opportunity to share some insights on environmental control and the risk of TB in healthcare workers in this webinar. So let us start with this. As we have already seen that cough is a transmitter of many airborne diseases, and majorly we can divide it into two parts. One is the component of large droplets, and one is the small droplets. So as already we have seen, the small droplets are the one which go in the smaller airways and the alveoli. So is TB a primarily transmitted through cough? हमारा नॉर्मली ऐसा मानना है कि खांसी से ही टीबी फैलती है, पर क्या ऐसा सच है क्या? तो लेट्स सी. तो हमारे पास वी डू हैव रिसर्च कि नॉर्मल सांस लेने के टाइम पे भी आपका टीबी का ट्रांसमिशन होता है. सो टीबी कैन बी स्प्रेड थ्रू नॉर्मल टाइडल ब्रीदिंग और नॉर्मल ब्रीदिंग आल्सो, एंड वी ब्रीथ 22,000 टाइम्स अ डे. सो यू कैन सी दैट it is generated by the TB is transmitted by both coughing as well as non-coughing mechanisms. So the point is, when we have such a disease which spreads by such mechanisms, both cough and non-cough mechanisms, so are we safe? So studies have shown that we healthcare workers are at a more increased risk of TB infection and TB disease. डॉक्टर साहू इन्होंने स्टार्टिंग में ही बताया था कि इन्फेक्शन और डिजीज दोनों अलग अलग रहते हैं. तो हेल्थकेयर वर्कर्स दोनों इन्फेक्शन और डिजीज दोनों के ऊपर मींस दोनों उनके पास इट इज एट अ वेरी हाई रिस्क. इन्फेक्शन मतलब वो कंडीशन है जब आपके बॉडी में टीबी के जंतु हैं बट दोज आर नॉट डिटेक्टेड और आपको सिम्टम्स नहीं है. और डिजीज वो है जब जंतु आ गए हैं आपके बॉडी में और आपको कॉफ, ब्रेथलेसनेस ये सब हो रहे हैं. So normally infection is considered as a high risk of developing to disease. तो हम TB healthcare workers दोनों infection और disease दोनों में we are at a high risk. So studies they have said कि इसका cause क्या है? What are the cause? So one of the causes that has been identified is inadequate TB infection control and occupational health services. So हमारा जो TB infection control है, अगर हमारे healthcare settings में it is not proper, so that could be one of the risk factors. The others are staffing shortages or insufficient fundings. So अगर हम हेल्थ केयर वर्कर्स रिस्क पर है तो हमारे साथ हम खुद ही रिस्क नहीं है, हमारी फैमिलीज भी रिस्क पर है. जस्ट अ मिनट. Am I audible?
Yes, sir.
Okay.
Yes, sir, you are audible.
Okay. So we are some risk, but हमारे साथ हमारी फैमिलीज और जो हेल्थ केयर वर्कर्स हैं, हमारी फैमिली और पेशेंट पर है.
Sir, I think you have joined from two systems. Can you log out from one of the system because your voice is not coming clearly?
Okay. Just a minute. I'll shut down the system. Can you please share the PPT slides from there?
Sure, sir.
Yeah. Yeah. Next slide. Next slide. Yeah. Next slide, please. Okay. So the next slide, please. This has already been covered. Next slide. Next. हाँ, next slide. Yes. तो हम लोग रिस्क पे हैं. तो हम ही नहीं, हमारे साथ हमारी फैमिलीज और तो पेशेंट्स हम जो देखते हैं वो भी रिस्क पर हैं. नेक्स्ट स्लाइड प्लीज. So what the studies have shown? The studies have shown that healthcare workers, the incidence of TB infection is 54%, the prevalence. So normally normal population में कितना prevalence है इसका? 1/3. So let's say about 30% prevalence normal population में, और हम लोगों में almost 50%, 54% है. So we are at a higher risk of developing TB infection. Next slide, please.
ओके और स्टडीज ने क्या पाया है कि टीबी इन्फेक्शन का रिस्क क्या है? इंक्रीज इन एज, मतलब एज मोर देन 40 years एंड योर एक्सपोजर और हेल्थ मींस वर्किंग एक्सपोजर ऑफ मोर देन 10 years, इट प्लेसेस द हेल्थ केयर वर्कर्स एट इंक्रीज रिस्क ऑफ डेवलपिंग टीबी इन्फेक्शन। सो अगर आपकी उम्र 40 साल से ज्यादा है और आप 10 साल से ज्यादा से काम कर रहे हैं तो टीबी इन्फेक्शन का रिस्क आपका काफी ज्यादा है। नेक्स्ट स्लाइड प्लीज। ओके ये इंडिया की पहली मेटा एनालिसिस थी, लास्ट ईयर पब्लिश हुई थी। So in this, they have calculated the actual prevalence of TB disease in healthcare workers. So the prevalence of TB disease was found to be 2391 cases per 1 lakh population of healthcare workers. And in normal population, it was about 312 per lakh population. So हम देखेंगे कि जो नॉर्मल पॉपुलेशन है, जो कॉमन पब्लिक है, उनमें प्रिवेलेंस है हर 1 लाख कॉमन पब्लिक में से 312 लोगों को होता है। और अगर हम हेल्थ केयर वर्कर्स को लेंगे तो 1 लाख हेल्थ केयर वर्कर्स में से 2391 लोगों को टीबी का रिस्क है। तो हम लोग ऑलमोस्ट 7 गुना ज्यादा टीबी डिजीज के रिस्क पर हैं। और रिस्क फैक्टर्स में जो सबसे ऊपर आया था दैट वाज पुअर वेंटिलेशन इन हेल्थ केयर सेटिंग्स। सो दिस वाज द वन ऑफ द मोस्ट इंपॉर्टेंट रिस्क फैक्टर्स। एंड देन द नेक्स्ट फैक्टर्स वर लैक ऑफ पीपीई, फ्रीक्वेंट एक्सपोजर्स। सो रिकमेंडेशन इन दैट स्टडी वाज, द सबसे इंपॉर्टेंट रिकमेंडेशन था यू इंप्लीमेंट स्ट्रिंजेंट इन्फेक्शन कंट्रोल मेजर्स इन द हेल्थ केयर सेटिंग्स। द नेक्स्ट वाज कंडक्ट रूटीन टीबी स्क्रीनिंग ऑफ हेल्थ केयर वर्कर्स, जो पहले बताया गया था। एजुकेशनल प्रोग्राम जैसे कि हम ये वेबिनार कंडक्ट कर रहे हैं, नेशनल टीबी स्क्रीनिंग गाइडलाइंस एंड हेल्थ केयर इंफ्रास्ट्रक्चर हमारा रोबस्ट होना चाहिए। नेक्स्ट स्लाइड प्लीज। तो ये स्टडी के फाइंडिंग्स थे। तो इस स्टडी के फाइंडिंग्स में हम देखेंगे कि जो लैबोरेटरी टेक्नीशियंस हैं, दोज आर एट ए हायर, सबसे मैक्सिमम रिस्क उनका है। द नेक्स्ट जो रिस्क है वो सिस्टर्स का है और उसके बाद फिर डॉक्टर्स का है। तो लैब टेक्नीशियंस एज वी हैव सीन आर एट द मैक्सिमम रिस्क ऑफ डेवलपिंग टीबी डिजीज। नेक्स्ट स्लाइड। और फिर फैक्टर्स उन्होंने देखे कि टीबी डिजीज डेवलप होने के फैक्टर्स क्या हैं। तो स्टडीज में पाया गया है कि 2 मेन फैक्टर्स हैं। एक, अगर आप ब्रेकफास्ट ठीक से नहीं करते, अगर आप बिना ब्रेकफास्ट की ड्यूटी पर जा रहे हैं, और दूसरा आपकी स्लीप एडिक्वेट नहीं है। तो दीज 2 फैक्टर्स हैव बीन फाउंड टू बी एसोसिएटेड विद एन इंक्रीज रिस्क ऑफ टीबी डिजीज इन हेल्थ केयर वर्कर्स। उसके बाद अगर आपका खाना अगर अच्छा नहीं है, आपका न्यूट्रिशन अच्छा नहीं है, बीएमआई कम है, इफ यू आर नॉट इन्वॉल्व इन स्क्रीनिंग फॉर टीबी इन हेल्थ केयर वर्कर्स, तो आपका रिस्क ज्यादा रहेगा। आपका एक्सपोजर कितना है टीबी पेशेंट्स को, और आपके डाइट में प्रोटीन है या नहीं। सो you are supposed to take care of all these factors for prevention of TB disease. Please remember, important factors are breakfast and sleep. Next slide, please. ये ऑलरेडी हमने पहले देखा है कि रिस्क फैक्टर्स लेबोरेटरी टेक्नीशियंस जो है वो सबसे ज्यादा रिस्क पर हैं, फिर आपके वार्ड्स वगैरह, और फिर ओपीडीज हैं। तो लैब टेक्नीशियन एज वी हैव ऑलरेडी सीन टीबी इन्फेक्शन डिजीज सबके रिस्क पर है। नेक्स्ट स्लाइड प्लीज। सो प्रिवेंटिव मेजर्स क्या क्या हम कर सकते हैं फॉर प्रिवेंशन ऑफ टीबी इन हेल्थ केयर वर्कर्स। नेक्स्ट स्लाइड। सो हम 3 प्रकार को हम 3 चीजों को टारगेट कर सकते हैं। एक है एजेंट जिसको हम बोलते हैं टीबी माइकोबैक्टीरियम ट्यूबरकुलोसिस। होस्ट यानी कि हम इंसान, और इन्वायरमेंट जो जहां से टीबी फैलता है। नेक्स्ट स्लाइड। सो एजेंट, तो टीपीटी जो है, जो टीबी प्रिवेंटिव थेरेपी है, वो हम एजेंट अगर लेटेंट टीबी इन्फेक्शन है तो उसमें टारगेट करते हैं, और अगर एक्टिव टीबी की बीमारी है तो उसमें हम उसको डायग्नोसिस और ट्रीटमेंट, दैट इज द मोस्ट इफेक्टिव मेजर अगेंस्ट एजेंट। होस्ट में आपका न्यूट्रिशन हमको कवर करना है, स्लीप, रेस्ट, स्ट्रेस और वैक्सीनेशन, ये फैक्टर्स हैं। और इन्वायरमेंट में सबसे इंपॉर्टेंट है आपका इन्फेक्शन कंट्रोल मेजर्स, सो दैट इज द मोस्ट इंपॉर्टेंट इन इन्वायरमेंट। सो जब हम एयरबोर्न इन्फेक्शन कंट्रोल देखते हैं तो आपके लार्ज और स्मॉल ड्रॉपलेट्स ऑलमोस्ट 5 फीट तक जाते हैं, और जो न्यूक्लियाई है वो ज्यादा दूर तक जाता है। तो इसलिए एक बेसिक जो फंडामेंटल है दैट इज टू कीप अ मिनिमम डिस्टेंस ऑफ 6 फीट बिटवीन 2 पेशेंट्स और डॉक्टर और पेशेंट्स। तो हमने पेशेंट से ओपीडी में हो या आईपीडी में हो, बात करते वक्त 6 फीट का डिस्टेंस मेंटेन करना है, और इसी तरह से हमें इसको इंप्लीमेंट भी करना है। नेक्स्ट स्लाइड प्लीज। सो हम एयरबोर्न इन्फेक्शन कंट्रोल को हम 3 पार्ट में डिवाइड कर सकते हैं। एडमिनिस्ट्रेटिव कंट्रोल जो ऑलरेडी लिया गया है, इसमें अभी हम आगे इन्वायरमेंटल कंट्रोल की तरफ बढ़ेंगे, और उसके बाद फिर हम पीपीई कंट्रोल्स। पीपीई कंट्रोल्स में 2 चीजें सिर्फ बता रहा हूँ कि पेशेंट ने सर्जिकल मास्क पहनना और हमने N95 मास्क पहनना, प्लीज ये इतना याद रखिए। नेक्स्ट स्लाइड। तो डिस्टेंस हमने बताया है 6 फीट के से ज्यादा होना चाहिए, और वी डू हैव आवर नेशनल गाइडलाइंस। अभी रिसेंट वापस विल बी हैविंग अ न्यू अपडेटेड वर्जन सून। थैंक यू। नेक्स्ट स्लाइड। सो जब हम इन्वायरमेंटल कंट्रोल में देखेंगे तो 3 प्रिंसिपल से हम इनको इन्वायरमेंटल कंट्रोल हम इंप्लीमेंट कर सकते हैं। सो इट वर्क्स बाय 3 प्रिंसिपल्स। द नंबर 1 इज रिमूवल। नेक्स्ट। रिमूवल में हम क्या करते हैं कि इन्फेक्टेड एयर जो है, जो दूषित एयर है अंदर का, उसे हम बाहर फेंकते हैं। डाइल्यूशन मतलब जो फ्रेश एयर है बाहर से, उसे हम अंदर लाते हैं। और डिकंटामिनेशन। डिकंटामिनेशन मतलब कि जो भी इन्फेक्टेड ऑर्गेनिजम्स हैं उन्हें हम इरेडिएशन जैसे यूवी लाइट्स या फिल्टर्स, उससे हम इसको डिकंटामिनेशन करते हैं एयर को। नेक्स्ट स्लाइड। सो इस तरह से हमारा इन्वायरमेंटल कंट्रोल काम करता है और ये बहुत ही इंपॉर्टेंट है। नेक्स्ट स्लाइड। सो इसके अंदर हमारे पास 4 मेन मैकेनिज्म्स हैं। एक है आइसोलेशन या स्पेसिंग, दूसरा है वेंटिलेशन। वेंटिलेशन इज नथिंग बट मूवमेंट ऑफ एयर, और फिर उसके बाद यूवी जर्मिसाइडल इरेडिएशन। ये यूवी लैंप्स रहते हैं जिससे हम बेसिलाई मारते हैं टीबी के। और हीपा फिल्टर। हीपा फिल्टर्स जो है वो जस्ट एयर प्यूरिफायर्स या एयर फिल्टर्स हैं। 99% एफिशिएंसी, 0.3 माइक्रोन्स के ऊपर के जो साइज के पार्टिकल्स हैं उन्हें वो फिल्टर कर लेते हैं। नेक्स्ट स्लाइड। सो अगर हम हियरकी देखें कि कॉस्ट इफेक्टिव कौन सा है, तो सबसे कॉस्ट इफेक्टिव इज प्रॉपर नेचुरल वेंटिलेशन। अगर आपके विंडोज और डोर्स हमने खुले रखे हैं अपने वार्ड में, और जो डोर्स और विंडोज हैं इनका टोटल जो एरिया है इट शुड बी मोर देन 20% ऑफ द फ्लोर सरफेस। दिस इज बेसिक। अगर आपने इतना कर लिया तो दैट इज वेरी सफिशिएंट। एयर एक्सचेंजेस आपके होने ही होने हैं। नेक्स्ट इज मैकेनिकल वेंटिलेशन। अगर हमारा नेचुरल वेंटिलेशन एडिक्वेट नहीं है तब हम एक्सॉस्ट फैन या दूसरे प्रकार के मैकेनिकल वेंटिलेशन यूज कर सकते हैं। और फिर नेक्स्ट इज सप्लीमेंटल। अगर इनसे भी नहीं हो रहा तो हम यूवी जर्मिसाइडल इरेडिएशन या हीपा फिल्टर्स यूज कर सकते हैं। नेक्स्ट स्लाइड प्लीज। अब ये देखिए, ये एक सीटिंग अरेंजमेंट है। ऑलरेडी 2 प्रकार के अरेंजमेंट है। एक में जैसे लाइन ऑफ वेंटिलेशन या लाइन ऑफ एयर फ्लो में डॉक्टर और पेशेंट दोनों बैठे हुए हैं। नेचुरल वेंटिलेशन का एक ड्रॉबैक है कि इसमें फ्लो किस डायरेक्शन में जाएगा या प्रेडिक्ट नहीं कर सकते। दिन के अलग अलग टाइम में फ्लो अलग अलग हो सकता है। रात में फ्लो अलग हो सकता है, दिन में अलग हो सकता है, दोपहर में अलग हो सकता है, सुबह अलग हो सकता है। सो आइडियली हेल्थ केयर वर्कर एंड पेशेंट दे शुड नॉट कम इन द सेम लाइन ऑफ एयर फ्लो। तो आप ऑब्लिक बैठ सकते हैं। पेशेंट एयर फ्लो के लाइन में रहा तो उसका जो कफ पार्टिकल्स हैं वो एक्सॉस्ट से या जिस तरफ की हवा जा रही है उस तरफ से बाहर जा सकता है। तो इतना आपको ध्यान रखना है। नेक्स्ट स्लाइड। अब वार्ड्स देखिए, वेल स्पेस्ड वार्ड्स, दिस इज वेरी इंपॉर्टेंट। 2 बेड्स के बीच में 6 फीट का डिस्टेंस होना चाहिए। मिनिमम हमें 6 फीट का डिस्टेंस 2 बेड्स में, स्पेसिंग अपने अच्छे होने चाहिए। तो ये 2 चीजें याद रखना है। खिड़कियां दरवाजे खोल के रखने हैं और स्पेसिंग 6 फीट रखना है 2 बेड्स के बीच में। इंडिविजुअल रूम्स रहे तो वहां पर हम दूसरी चीजें भी यूज कर सकते हैं इन एडिशन टू वेंटिलेशन। और एयरबोर्न आइसोलेशन एरियाज ये हम हॉस्पिटल में रख सकते हैं, ऑलरेडी बताया गया है। नेक्स्ट स्लाइड। ये देखिए, लेफ्ट में जो देखेंगे दैट इज स्पूटम, ये कलेक्शन एरिया। तो वहां पे आप देखेंगे कि ऑलमोस्ट ओपन स्ट्रक्चर है। एक आपका ये शेड दिया हुआ है एंड इट इज इन एन आइसोलेटेड एरिया। सो दूसरे पेशेंट्स का मूवमेंट नहीं है। सो दिस इज एन आइडियल स्पूटम कलेक्शन एरिया। और दूसरा पेशेंट एरिया देखिए सीटिंग का, तो वो भी एकदम अच्छा वेंटिलेटेड है, वेल वेंटिलेटेड, अवे फ्रॉम द रूटीन पेशेंट एरिया। सो दिस इज वेरी इंपॉर्टेंट। नेक्स्ट स्लाइड प्लीज। इफेक्टिव वेंटिलेशन के लिए हमें क्या चाहिए? इसका बेसिक एक ही प्रिंसिपल है, जो शुद्ध हवा है या क्लीन एयर है वो अंदर आए और कंटेमिनेटेड एयर बाहर जाए। तो इस तरह से हम फ्लो मॉनिटर करते हैं। एयर एक्सचेंजेस जो है वो आइडियली हेल्थ केयर सेटिंग में 6 एयर चेंजेस पर आवर होना चाहिए, या उसको पर पेशेंट अगर देखेंगे तो इट शुड बी 60 लीटर्स पर सेकेंड पर पेशेंट। और हाई रिस्क सेटिंग्स में इट हैज टू बी 12 एयर चेंजेस पर आवर। और पेशेंट वाइज देखेंगे तो 80 to 160 लीटर्स पर सेकेंड पर पेशेंट। नेक्स्ट स्लाइड। तो ऑलरेडी मैंने बताया कि नॉर्मली हेल्थ केयर सेटिंग्स में मिनिमम 6 चाहिए, और हाई रिस्क सेटिंग्स जैसे एमडीआर वार्ड्स रहे, ब्रोंकोस्कोपी यूनिट्स रहे हमारे, या दूसरे जहां पे भी हम एरोसोलाइजेशन ऑफ पार्टिकल्स होते हैं, तो वहां पे 12 एयर चेंजेस मिनिमम होने चाहिए। नेक्स्ट नेक्स्ट स्लाइड। यस, तो यहाँ पे हम देख रहे हैं कि अगर 12 एयर चेंजेस पर आवर अगर हो रहे हैं तो उसमें क्या हो रहा है हमारा कि पेशेंट जाने के बाद 99% ऑफ जो आपका ये है पार्टिकल्स वो आपके आधे घंटे में ऑलमोस्ट निकल रहे हैं। तो इसका प्रैक्टिकल इंप्लीकेशन क्या है कि जब भी हमारा ओपीडी खत्म हो जाता है तो ओपीडी के बाद ऑलमोस्ट आधा घंटा आप आपके खिड़कियां दरवाजे खोल के रखें, तो उसके बाद आपका इट विल बी टोटली जो पार्टिकल्स हैं वो 99% आपके निकल जाएंगे। So it takes with the air change of with the air change of 12 ACH per hour, आप ऑलमोस्ट आधे घंटे में 99% ऑफ ऑर्गेनिजम्स बाहर निकल सकते हैं। ये फॉर्मूला है उसका ACH का कि एवरेज फ्लो डिवाइड बाय द रूम वॉल्यूम। नेक्स्ट स्लाइड। ओके, तो वेंटिलेशन 3 प्रकार के रहते हैं। एक नेचुरल वेंटिलेशन है, ये मूवमेंट ऑफ एयर है इन नेचुरल रिसोर्सेज, नेचुरल फैक्टर्स के थ्रू। दूसरा है मैकेनिकल वेंटिलेशन जहां हम असिस्टेड या एक्सॉस्ट फैन या एचवैक यूज करते हैं। और तीसरा है हाइब्रिड, हम नेचुरल और मैकेनिकल दोनों को मिक्स करते हैं। जैसे कि कहीं नेचुरल आपका प्रॉपर हो नहीं रहा तो हम वहां एक्सॉस्ट फैंस यूज करेंगे। नेक्स्ट स्लाइड प्लीज. ओके, तो नेचुरल वेंटिलेशन इज द लो कॉस्ट एंड मेंटेनेंस फ्री. इंपॉर्टेंट क्या है? खिड़कियां और दरवाजे होना इंपॉर्टेंट नहीं है, उन्हें खोल कर रखना इंपॉर्टेंट है. इन ऑल सीजन्स दे शुड बी ओपन. पेशेंट्स को लगा तो हम एक्स्ट्रा क्लोथिंग वगैरह दे सकते हैं ठंडियों के टाइम पे. एक्सॉस्ट फैन सप्लीमेंट्स, अगर नेचुरल वेंटिलेशन आपका प्रॉपर नहीं हो रहा है तो फिर आप एक्सॉस्ट फैंस भी यूज कर सकते हैं फॉर मिक्स वेंटिलेशन. नेक्स्ट स्लाइड प्लीज. यस, सो ये हाइब्रिड वेंटिलेशन है. नॉर्मली हम सीलिंग फैंस जो रहते हैं वो क्या काम करते हैं? मिक्सिंग ऑफ एयर को काम करते हैं. एक्सॉस्ट फैन आपको फ्लो में हेल्प करते हैं. और बहुत जगह ये यू हैव दिस वर्ली बर्ड्स, तो ये क्या होता है, गर्म हवा जब हम सांस बाहर छोड़ते हैं तो गर्म हवा ऊपर जाती है और उससे फिर वो घूमकर बाहर निकलती है. तो दोज आर वर्ली बर्ड्स. नेक्स्ट स्लाइड प्लीज. फैंस. फैंस हमें दो प्रकार के, एक सीलिंग फैन रहता है और एक्सॉस्ट फैन. तो एक्सॉस्ट फैन क्या काम करता है? वो वेंटिलेशन का, वो फ्लो जो है फ्लो जनरेट करता है. या तो वो बाहर से अंदर की तरफ हम यूज कर सकते हैं या अंदर से बाहर. तो जिस प्रकार भी हमें फ्लो ज्यादा करना है वहां पे हम यूज कर सकते हैं. और सीलिंग फैन जो है वो काम करते हैं मिक्सिंग ऑफ एयर. जो रूम में हवा मिक्स करते हैं तो वो सीलिंग फैन काम करते हैं. नेक्स्ट स्लाइड प्लीज. अब ये देखिए, नॉर्मली हम अगर एक्सॉस्ट फैन हम लगा रहे हैं तो उसके सराउंडिंग एरिया को हमको क्लोज करना है, वरना क्या होगा, वहां पे उसके सराउंडिंग एरिया से ही हवा अंदर जाएगी और बाहर आएगी, तो वहां पे क्लोज सर्किट या क्लोज लूप क्रिएट हो जाएगा. सो इट विल नॉट इफेक्टिवली हेल्प इन द चेंजिंग द एयर फ्रॉम द रूम. सो एयर चेंजेस में वो हेल्प नहीं करेगा और लोकल ही सर्किट बन जाएगा. सो अगर उसको हमें अच्छी तरह से यूज करना है तो उसके आसपास का एरिया हमें ब्लॉक करना है. नेक्स्ट स्लाइड प्लीज. अब ये देखिए, यहाँ पर हम लेफ्ट साइड पर देख सकते हैं कि जो आपका एक्सॉस्ट फैन है उसके आसपास का एरिया ब्लॉक्ड है. देन दिस विल वर्क एफिशिएंटली. अब राइट साइड में देखेंगे, एक्सॉस्ट फैन है उसके ऊपर उन्होंने एक खिड़की लगा दी थी. तो अगर इस टाइप का कुछ है तो उसे खोलना है, क्योंकि एक्सॉस्ट फैन काम करने के लिए अंदर और बाहर दोनों उसका खुला रहना जरूरी है. देन ओनली द फ्लो ऑफ एयर विल टेक प्लेस. नेक्स्ट स्लाइड. ये देखिए, अगेन इट इज वेरी इंपॉर्टेंट कि खिड़कियां अपनी खुली रहें. पार्टीशन यूजुअली नहीं होना चाहिए, पर अगर पार्टीशन हम रख रहे हैं तो हाफ पार्टीशन यूज करें. ऊपर का पार्टीशन हमें ऊपर की तरफ खाली रखना है. तो क्या होगा, जब हम सांस बाहर छोड़ते हैं तो जो गर्म हवा है वो ऊपर जाएगी और वहां से फिर वेंटिलेशन होके वो निकल जाएगी. नीचे की स्लाइड्स में हम देख रहे हैं कि खिड़कियां हमेशा बंद रहती हैं, तो खिड़कियां हमें बंद नहीं रखनी है. हम जब भी वार्ड में राउंड्स के लिए जाएं या फिर पेशेंट्स देख रहे हैं ओपीडी में, तो खिड़कियां हमेशा खुली रहनी चाहिए. नेक्स्ट स्लाइड. अब ये ऑलमोस्ट 4 दिन पहले का ये फोटोग्राफ है. सो हियर यू कैन सी कि फर्स्ट स्लाइड में हमने देखा कि आपकी खिड़कियां और वेंटिलेटर्स सारे बंद हैं और पेशेंट है वहां पर, और दो बेड के बीच का डिस्टेंस भी आप देख सकते हैं काफी कम है. नेक्स्ट स्लाइड प्लीज. हाँ, सो हमेशा पॉइंट क्या है, विंडोज और जो डोर्स हैं वो हमेशा खुले रखने हैं और दो बेड्स के बीच में मिनिमम डिस्टेंस 6 फीट का रखना है. नेक्स्ट. अब ये देखिए, सेम हमने खिड़कियां खोल दी, डिस्टेंस बढ़ा दिया, तो नाउ दिस विल बी अ गुड वेंटिलेशन. तो एंड एयरबोर्न इन्फेक्शन कंट्रोल के हिसाब से भी ये हो जाएगा. तो ये सब हमें हमारे फील्ड में, हमारे वार्ड में हमें इंप्लीमेंट करना है. नेक्स्ट स्लाइड. राइट, सो हम ये देख सकते हैं कि ऑलमोस्ट चेंजेस के बाद इफेक्टिव वेंटिलेशन हमारा हो जाएगा. नेक्स्ट स्लाइड. वेंटिलेशन दो प्रकार के होते हैं, क्रॉस वेंटिलेशन या सिंगल. हमेशा क्रॉस वेंटिलेशन सबसे इफेक्टिव है, क्योंकि उसमें फिर एक तरफ से हवा अंदर आ सकती है, दूसरी तरफ से बाहर जा सकती है. सिंगल विंडो वेंटिलेशन दैट विल बी लेस इफेक्टिव. नेक्स्ट स्लाइड प्लीज. सेम पार्टीशंस अगर रहे तो वो आपको वेंटिलेशन की तरफ रुकावट पैदा करते हैं. सो इन एब्सेंस ऑफ पार्टीशंस इट विल बी अ गुड इंफ्रास्ट्रक्चर, बट पार्टीशन से तो हाफ पार्टीशंस रखें. नेक्स्ट स्लाइड. ऑलमोस्ट अभी लास्ट टाइम मैडम ने दिखाया था लास्ट स्लाइड्स में कि नेगेटिव प्रेशर रूम्स, ये भी एक प्रकार का ये है. अगर सिंगल रूम्स है, इसमें एक तरफ से हवा अंदर आती है और दूसरी तरफ से बाहर जाती है. बाहर जाने का जो फ्लो है वो दैट इज मोर, सो देयरफॉर नेगेटिव प्रेशर इज देयर. पेशेंट कुछ भी खांसता है तो हेड एंड की तरफ वो ऑलमोस्ट सकिन हो जाता है. तो दैट इज हाउ नेगेटिव प्रेशर रूम वर्क्स. नेक्स्ट स्लाइड. अब ये देखिए, ये इन्होंने स्टडी किया था कि एक रूम में CO2 बिल्डअप, अभी मैडम ने एक आपको मॉनिटर भी दिखाया कि CO2 वो मेजर करता है. तो CO2 बेसिकली क्या मेजर करता है, हमारे एक्सपायर्ड एयर में CO2 ज्यादा रहता है. तो ज्यादा लोग अगर रहे तो रूम में आपका CO2 का लेवल्स बढ़ जाएंगे. अब इन्होंने यहाँ पे दिखाया कि जैसे खिड़कियां और दरवाजे खोली तो CO2 लेवल्स आपके कम हो गए हैं. सो a decrease in CO2 level occurs when you open the doors and windows. So CO2 levels is indirectly due to expired air, और expired air में ही आपके जंतु ज्यादा रहते हैं. तो खिड़कियां और दरवाजे अगर हम खोलेंगे तो नेचुरल वेंटिलेशन काम करेगा और इफेक्टिवली काम करेगा. नेक्स्ट स्लाइड. एयर कंडीशनिंग जो है वो वेंटिलेशन का ऑलमोस्ट दुश्मन है, इट इज एन एनिमी. क्योंकि उसमें आपके विंडोज और डोर्स आप क्लोज कर देते हैं और एसी चालू करते हैं, तो वहां पे एयर सर्कुलेशन होते रहता, तो वहां पर आपके एयर चेंजेस इफेक्टिवली नहीं होंगे। नेक्स्ट स्लाइड प्लीज। पर एयर कंडीशन में भी हम वेंटिलेशन को हम यूज कर सकते हैं कि एक तरह से हम एंट्री और आउटलेट दे दें, बट दैट विल नॉट बी एनर्जी एफिशिएंट। इट विल बी हाईली द इलेक्ट्रिसिटी कंज्यूमिंग एनर्जी कंजम्पशन विल बी हाई। सो इट इज बेसिकली रिकमेंडेड कि नेचुरल वेंटिलेशन जहां पे भी हाई रिस्क एरियाज हैं to be predominantly fall back on the ventilation. Next slide. Right. Next slide, please. Yes. So WHO के रिकमेंडेशन क्या है? 2022 में WHO ने रिकमेंडेशन दिया था कि वेंटिलेशन और HEPA फिल्टर्स बोथ आर रिकमेंडेड इन सेटिंग्स विथ हाई रिस्क ट्रांसमिशन। तो हमने वेंटिलेशन देख लिया और HEPA फिल्टर्स हम आगे देखेंगे। तो HEPA फिल्टर्स, नेक्स्ट स्लाइड प्लीज। ओके, नेक्स्ट हम आते हैं यूवी इरेडिएशन के ऊपर। तो डब्ल्यूएचओ का एक रिकमेंडेशन ये भी है कि यूवी जहां पे भी हाई रिस्क सेटिंग है वहां पर हम अपर रूम जर्मिसाइडल अल्ट्रावायलेट सिस्टम्स यूज कर सकते हैं। पर इसमें इंपॉर्टेंट ये है कि हमारा अगर वेंटिलेशन प्रॉपर नहीं हो रहा तो हम इसको यूज करेंगे, और इसमें डिजाइन, इंस्टॉलेशन, ऑपरेशन और मेंटेनेंस, प्रॉपर मेंटेनेंस बहुत इंपॉर्टेंट है। और आपका यूवी रेडिएशन 254 नैनोमीटर्स पे काम करता है, इससे ज्यादा नहीं होना चाहिए, इससे कम नहीं होना चाहिए। नेक्स्ट स्लाइड प्लीज। अगर इससे कम हुआ तो इसकी एफिकेसी कम हो जाती है, और अगर इससे ज्यादा हुआ, 254 नैनोमीटर से ज्यादा हुआ, तो इसके फिर एडवर्स इफेक्ट्स लाइक फोटोकेरेटाइटिस, एरिथेमा और कैंसर, ये सब चीजें हो सकती हैं। तो उसके लिए हमें इसका प्रॉपर मेंटेनेंस, प्रॉपर चेकिंग, ये सब करना है हमें। तो इसके लिए अलग से ये आते हैं, मीटर्स आते हैं विच इट कैन बी चेक्ड। नेक्स्ट स्लाइड। तो नॉर्मली हम जब यूज करते हैं यूवी लाइट्स को, अगर हम यूज कर रहे हैं वार्ड में, तो आइडियली वो हाई सीलिंग पे होना चाहिए। मिनिमम आपका जो हाइट रिक्वायर्ड है दैट इज 2.5 मीटर्स, उसके ऊपर हम उसको फिक्स करेंगे, और उसके साथ हमें एक मिक्सिंग के लिए एयर फैंस देने हैं। तो जब मिक्सिंग होगा, सर्कुलेशन होगा, तो ये काम करेगा। गर्म हवा आपकी जो है वो ऊपर जाएगी, यूवी रेडिएशन होगा, और वहां से फिर आपकी डिसइंफेक्टेड हवा फिर नीचे आएगी। तो इसको हमें मिक्सिंग के साथ काम करवाना है, यूवी जीआई इरेडिएशन को। नेक्स्ट स्लाइड प्लीज। डिपेंडिंग ऑन द हाइट आपके पास ये अलग अलग मॉडल्स में है। हाइट 3 मीटर के ऊपर है तो अलग मॉडल्स हैं, और 2.5 से 3 मीटर की तरफ है तो यू हैव डिफरेंट मॉडल्स। नेक्स्ट स्लाइड। ये हीपा फिल्टर्स हैं। तो दीज आर हाई एफिशिएंसी फिल्ट्रेशन यूनिट्स। मैकेनिकल वेंटिलेशन को ऑल्टरनेटिव, अगर वहां पर आपके पास वेंटिलेशन प्रॉपर नहीं हो पा रहा है तो आप इसको हीपा भी यूज कर सकते हैं। 0.3 माइक्रॉन से ज्यादा 99.97% फिल्ट्रेशन रेट है इनका एफिशिएंसी। और स्मॉल या क्लोज रूम रहे जहां पे कम पेशेंट्स हैं तो वहां पे इनको यूज कर सकते हैं। नेक्स्ट स्लाइड। इंपॉर्टेंट पॉइंट ये है कि यूवी रेडिएशन और हीपा फिल्टर्स, इसको हम एडजंक्टिव तभी यूज करेंगे जब आपके एडमिनिस्ट्रेटिव और वेंटिलेशन मेजर्स आपने प्रॉपरली एड्रेस किए हैं। बिना एडमिनिस्ट्रेटिव और वेंटिलेशन मेजर्स के जस्ट इनको लगाना, इसका फुल एफिकेसी नहीं होगा। सो इट इज ऑलवेज रिकमेंडेड कि हम एडमिनिस्ट्रेटिव वेंटिलेशन जितना हो सकता करें, और उसके बाद फिर हम इन तक जो एडिशनल चीजें हैं उन तक जाएं। सो टेक होम मैसेज हम क्या बोल सकते हैं कि हेल्थ केयर वर्कर्स जो हैं, हम सब टीबी इन्फेक्शन और टीबी डिजीज के हाई रिस्क पर हैं। इफेक्टिव टीबी प्रिवेंशन स्ट्रेटेजीज जो हमारे लिए रहेंगे वो क्या क्या है? गुड न्यूट्रिशन इंक्लूडिंग गुड न्यूट्रिशन इंक्लूडिंग डेली ब्रेकफास्ट। So good nutrition including daily breakfast, that is a good TB prevention strategy. Sleep, rest, TB preventive therapy, early diagnosis and effective management of all TB cases, TB screening in healthcare workers, ये सब चीजें हमें करनी है। और importantly airborne infection control measures, effective environmental control measures क्या क्या है? Isolation, spacing, proper ventilation, UV GI irradiation and HEPA filtration. So this is effective environmental control measures. Distance between two patient beds in ward should be 6 feet, and we need to keep doors and windows open in healthcare settings, OPD, IPD, as well as in our hearts and societies for people with TB. Thank you. Next slide. Thank you.
Thank you, sir. We look forward to applying these insights in our work and continuing to learn from your expertise. Thank you once again for your time and your contribution. Our next speaker here with us is Dr. Manpreet Bhalla, Honorable Director of our Institute, NITRD, and Head of Microbiology Department. Ma'am is going to deliver a talk on the topic Laboratory Biosafety and Personal Protection in Airborne IPC. Ma'am, welcome you on TV.
Thank you. My presentation is on biosafety. So it's different from the earlier presentations. That was administrative and environmental controls. So I'll be talking about specifically the lab part, and it may be slightly technical, but I will try to make it simple only. So first, coming to the definition of biosafety, what do we mean by biosafety? So these are the measures to prevent, which prevent the exposure to the biological hazards, and we need to do biosafety for which all people, persons, for lab personnel. We need to make our environment safe and also to make as a public health measure. And this can be implemented through risk assessment, containment, and training. So, classification of laboratories. So, based on the biosafety levels, we have a classification of laboratories, and according to that, there is a risk of infection. तो हमारे पास तीन levels होते हैं: low risk laboratories, moderate risk laboratories, and high risk laboratories. So, depending on this, there are different precautions to be taken. This is I'll be detail में नहीं जाऊंगी मैं. So what all things we need to consider when we are doing a risk assessment. तो we need to see कि bacillary load जो भी हम sample handle कर रहे हैं, like usually sputum or cultures, what is the likelihood of bacteria to be there in that sample, the mode of transmission, कैसे वो spread हो सकता है, हैंडलिंग, जब हम हैंडलिंग करते हैं सैंपल को मैनिपुलेशन करते हैं, एंड क्या क्या उसमें हो सकता है विच कैन लीड टू एरोसॉल फॉर्मेशन, एंड द नंबर ऑफ मैन्यूवर फॉर ईच टेक्निक, कितनी बार हम उसको फ्रीक्वेंटली हम वो करते हैं मैनिपुलेट, सो दैट ऑल्सो विल इन्फ्लुएंस. टेस्टिंग द वर्कलोड ऑफ द लेबोरेटरी एज वेल एज इंडिविजुअल टेक्नीशियंस, कि एक टेक्नीशियन को कितना काम करना है per day, location of the laboratory, the epidemiology of TB and patient population, and also most important is the level of expertise. Some lab technicians are those who are experienced. They will take more precautions and do this. The level of infection prevention will be better, and also if their level of training is high, so they will be able to maintain it better. The health of the laboratory staff, obviously, if someone has any comorbidity, so that and some immunosuppressive conditions, so they have to take more precautions. And the availability of containment equipment, I will be talking about this equipment, whatever is in the lab, the equipment which we use for prevention from for biosafety, the facility safeguards, and adherence to the standard operating procedures. So in the lab, we have standard operating procedures for every step, and that is the most important thing. Next. So based on this risk precaution levels in the laboratories, first column you can see the risk level of the laboratory and the different hierarchy levels of the TB laboratories in the NTP and the activities which we are doing in the labs. So in the जैसे मैंने आपको पहले बोला low risk lab. So these labs are situated at the periphery or district levels, and usually they are the TB detection centers. And what activities we do here, the smear microscopy is done, or now rapid NATs like TrueNAT or CBNAT also may be performed at these sites. The moderate risk group is this also is at a slightly higher level lab. So these labs may be doing the culture and DST laboratories, that is the intermediate reference laboratories, but all activities like which are there for the low risk lab, that has to be obviously there for the moderate risk lab. In addition, if they are doing processing and concentration, like we are handling the samples, we are doing the processing of the samples and inoculation on the solid culture, not on the liquid culture. And if the direct LPA is being done, that is directly from the sputum sample, that is the primary LPA. So for all these facilities, these are moderate risk level laboratories. And these are the activities which are done there. High risk laboratory is a TB containment laboratory. So this is at a higher level. It is a culture. It may be situated at a STDC, culture and DST laboratory, or an intermediate reference laboratory, or a national reference laboratory, where we handle liquid culture and DST also is done. So we need more level of protection here. So again, all activities which are there for a low risk and moderate risk lab, as well as because we are doing liquid culture manipulation for identification or DST, or we are doing indirect LPA, that is first we do the culture and from the culture we do the LPA. So for this is a high risk TB containment laboratory. And these are the classification of infective microorganisms by the risk groups. So these are organisms other than mycobacteria also. So they are classified into various groups like risk group 1, which is no or low individual or community risk. Risk level group 2, which is moderate individual or low community risk, and risk group 3, which is high level community risk, and risk 4 is a very high individual and community risk. So, which are the microorganisms in the risk group 1 which are unlikely to cause human or animal disease? So, in this, the examples like fungus like Aspergillus, E. coli, Lactobacillus, acidophilus, these are the low risk, risk group 1. Risk group 2 is microorganisms that can cause human or animal disease but are rarely serious, or for which effective treatment and preventive measures are available, and risk of spread of infection is limited. So in this, bacteria like E. coli, Streptococcus pneumonia, Salmonella, cholera. Risk group 3. So Mycobacterium comes in the Mycobacterium tuberculosis in the risk group 3 group. That are those are the microorganisms that usually cause serious human or animal disease, but treatment or preventive measures are available, but they do not spread from one infected, but like TB can spread from one infected individual to another. Risk group 4 is the very high levels, like mainly the viruses like Ebola virus, Marburg virus, and Lassa virus. So these are the different risk groups. What are the coming to the procedural risk for the lab personnel? So as I told you, depending on the risk level, so there are different levels of risk. For if it at the administration room, there is a very low relative risk. It is only 1. So relative risk of administrative staff is similar to the general community. So it is very low risk. So in the lab where we are doing microscopy, it is a low risk of generating infectious aerosols when we follow safe practices. But tubercle bacilli load is variable in materials, so may be performed on. We have to be careful, and this can be performed on an open bench also if we are doing only microscopy, but with caution. If you are doing a gene expert and TrueNAT, this is also low risk. It is the same risk like a smear microscopy, equivalent to smear, and to but depending on the load of bacteria in the sample. And the viability of bacilli, like in case of gene expert, we add the lysis buffer, so the bacteria becomes non-infectious within 15 minutes, and DNA extraction step inactivates the AFB. So this can even this can be performed in an open bench if environment conditions are as per. So we have already talked about environmental conditions. So if they are as per the proper, we have exhaust and we have the air changes occurring, so we can do it in an open area also. Then coming to the culture, this is a moderate risk. So it's a marginally increased risk, and it is more risk compared to smear microscopy. Viability processing, usually we do the processing of samples. This kills 70 to 90% of the bacilli, but usually there are steps of processing. So during that time, it may be infectious. And usually we recommend a biosafety cabinet with good microbiological practices when we are handling cultures. For LPA, again, you can go through, it is like I've already told you, specimen processing should be performed in biosafety cabinets with good microbiological practices. If you are doing combined culture and DST, these are very high risk and should always be done in a biosafety cabinet, and with a good microbiological practice. LPA indirect is just like doing a culture. So for that also we need a biosafety cabinet. Next. So there are different biosafety levels. Biosafety level 1, 2, 3, and 4. I've told you. BSL 1 is low risk agents with minimal precautions. BSL 2 moderate risk. For these we have to use personal protective equipment and biosafety cabinets. Biosafety level 3, high risk pathogens. We have to have controlled access. And BSL 4 is the deadly agents like Ebola virus, and which need the maximum containment. What are the components of biosafety? So there are different definitions. We should understand what is containment. So it refers to safely managing infectious particles in the laboratory where they are being handled or maintained, and we can achieve it through a combination of primary and secondary containment measures. तो ये हम क्या कंटेनमेंट क्या होता है, और इसमें दो टाइप का होता है, प्राइमरी और सेकेंडरी. प्राइमरी क्या होता है, by good microbiological technique and use of safety equipment like personal protective equipment. And secondary में क्या होता है, we have to do good operational procedures and there should be a good facility design. Good microbiological lab practices. So the most important thing is that only authorized personnel should be permitted access to the laboratory. ऐसे restricted entry होनी चाहिए. ऐसा नहीं है कि कोई भी बाहर से आके अंदर लैब के अंदर तक जा रहा है, because it is an infectious area. And secondly, the refrigerator of the laboratory or working area, these are just the basic things. We should not use them for storing food. खाना नहीं store करना उसमें, और we should not eat, drink, smoke in the lab. Also, we should, when we are using some pens, pencils जो हम use करते हैं lab में, उसको we should not put them in the mouth because they are infectious. Next. So this is the best behavioral practices. अगर किसी के हाथ पे wound या cut हो, so they should be covered before entering the lab. If you should try to not wear any jewelry like bangles and all should not be worn. Rings and bangles should be removed. It's just like going to operation theatre. So before going to the operation theatre, because they can be act as sources and the bacteria can be lodged in that, even if we are wearing gloves. And most important is hands should be washed with soap. So when all we need to wash the hands, like there are 5 moments of hand hygiene when we are handling patients. In the lab, when we are handling samples, when all we should wash the hands. So we should wash with soap and water after we are handling the biological materials, before donning and doffing the PPE, before leaving the laboratory, or whenever hands are visibly or believably soiled or contaminated. अगर आपके हाथ पे कुछ आपको लग रहा है कि कुछ सैंपल गिर गया है या कुछ ग्लव आपका फट गया है, उसमें से सैंपल गिर गया है, then again you need to wash your hands. And on the right side, these are, I think we all know how to, what are the steps of hand hygiene, which are the parts of the hand which should be covered. So these are the different steps and we should follow them when we are doing the hand washing. So use personal protective equipment, that is gloves, gowns and all, depending on the anticipated exposure. So again, depending on the type of work you're going to do in the lab, I'll be telling you what all PPE we should wear. Work area should be clean. Avoid using like your mobile phones and laptops should not be used when you're working in the lab. Ensure the work is done carefully without haste. We should not be in a hurry so that there is no, and if accidentally any spill or any infectious material occurs, then अगर कुछ हमसे गिर जाता है गलती से कभी-कभी, तो उसको we have to clean with suitable disinfectants. Like 5% phenol, what we use in hypochlorite we use. Then there are different procedures होते हैं जब हम करते हैं लैब में, हम pipetting करते हैं, we add reagents. So when we are using a pipette, you should do it gently, not vigorously. And when you are adding a reagent to a liquid again, so all these basic lab SOPs have to be followed. Then when we are opening any tubes, we have to carelessly tapping or flipping should not be done. And brief centrifugation, like after centrifugation, immediately the tube should not be opened because there will be aerosol generated and we have to wait for some time. Then we use loops. Ideally, we should use disposable loops because if we use other loops like reusable ones and we heat them in between, again that may lead to aerosol formation. Adhere to additional biosafety precautions related to this I've already said, depending on the risk level of the laboratory. Next. Mouth pipetting, again, we should not do mouth pipetting. Always when we are using handling specimens, we have to wear gowns, and the disposable gowns should never be reused. Avoid making contact of the face with the glove. You should not don't touch your face with your gloved hand. So many of the precautions are just like what we were following in the COVID-19 times. And after using the gloves, remove them aseptically and wash your hands. Face shield, safety goggles should they are to be used only where we expect that splashes may occur, such as when we are preparing some disinfectant solutions or reagents. Again, these are some more do's and don'ts. Avoid using syringes. Avoid recapping, removing needles. Replace glassware or plasticware whenever possible. We have to check before using the glassware if they are cracked or damaged. And again, very important, sharps, जो needles होती है, broken glass है, they should be discarded in puncture-proof containers fitted with sealed covers. एंड दैट कंटेनर शुड हैव अ सुटेबल, उसके अंदर एक डिसइंफेक्टेंट होना चाहिए और वो डिसइंफेक्टेंट पूरा ऊपर तक नहीं भरना है, हमें उसको 3/4 ही भरना है सो दैट ये सारा मटेरियल उसमें डिप हो जाए. नेक्स्ट, नाउ कमिंग टू द सेफ्टी इक्विपमेंट व्हाट वी यूज इन द लैब. नेक्स्ट, so and the personal protective equipment, so gloves, gowns, mask, head cap, proper donning and doffing, and regular inspection and disposal of PPE. This is important. These are the where we use lab coats and where we need to use gowns. So disposable and non-disposable lab coats are available. Some have elastic waistbands and they are commercially available with long sleeves and they should be fully buttoned. And to be used for low to moderate risk laboratories, note that these lab coats should not be worn by while manipulating culture or conducting the DST. So for this we have to use the laboratory gowns. So and they should be ties at the neck and waist and full cover on the front and long elasticide cuffs, and they should be made of non-absorbent material. The gown should be long enough to cover the lap because if there is any spill in the lap, that can be taken care of. Now respirators, we know what are respirators. They are protect the users from aerosols and usually not required in low risk laboratories, but they should be worn by manipulating cultures. And so more than 95% of infectious particles which are more than larger than 0.2 millimeters are filtered by these respirators. Normally we use the N95 and the FFP2 respirators. They are lightweight, disposable, and they cover the nose and mouth have to be covered. So this is so whenever we are wearing a respirator, before wearing usko check karna hai. We have to check a few things. There should be no holes in that. The strap should be intact. This strap should not be overstepped. So first step is hold the respirator in the palm of your hand and straps underneath. Then place the respirator under the chin, second step, and place over the face gently. Pull the upper headband over the head and pull it high at the back. First you pick up the upper headband, then pull the lower headband. Adjust and mold the metal strap to get the nose clip. With the help of fingertips, you press on the nose tips and using only one hand. And you have to breathe in and out to confirm that there are no leaks. Then when we are removing, we have to be careful. First remove the gloves, wash your hands, then remove the mask. So first locate and pull over the lower headband, then remove the respirator from the face, hold both the straps in one hand and dispose the respirator. Store or usually when we are handling, we try to don't reuse the masks and wash the hands again. Again for gloves also, these are the precautions. Remove one glove by grasping it under the cuff and rolling the glove off the hand. Hold the removed glove with your opposite gloved hand. Tuck fingers inside the inside the cuff of the gloved hand to avoid the touching. So all these steps are, ये सब हमें करना है ताकि हम उसका बाहर का पार्ट नहीं टच करना है हमें gloves का. Peel the glove from the inside and roll it over the other glove and dispose of the gloves in a biohazard waste. So this is how we remove the gloves. So just important do's and don'ts. Wear disposable gloves only and before use check that they are intact. Gloves should always cover the gown cuff रिमूव torn और विजिबली कंटेमिनेटेड ग्लव्स। अगर उसमें आपको दिख रहा है कि वो फटा हुआ है या कुछ उसमें कुछ गिरा हुआ है, तो देन यू हैव टू रिमूव द ग्लव्स एंड डिस्कार्ड देम इन द बायोहैजर्ड बिन, एंड आफ्टर यूज रिमूव द ग्लव्स एसेप्टिकली एंड वॉश योर हैंड्स। एंड जो नहीं करना है हमें, बहुत इंपॉर्टेंट है, डू नॉट ब्रिंग ग्लव्स आउटसाइड ऑफ द लैब, डू नॉट रीवेयर यूज ग्लव्स, never handle the door knobs, handles, telephones, pens, paper with your gloved hands because they are contaminated and they may spread the infection. Next. These are personal, some face, eyes and face protector. It is based on the type of lab activities to be performed. Usually we don't use, only if you are anticipating that some splashes may occur, or like in COVID, when we are handling the samples, we needed to wear this goggles and shields. Footwear also, lab personnel should wear foot protection, especially in areas where chemical and biological hazards are present, and it should always be tight fitting. Next. This is again a sequence of donning and doffing of PPE. So the steps are important. So first you have to wear the gown, then the respirator, and then the gloves. So first completely wear the gown, usually from neck to knee, and it should be tied at the back. And then second step, you wear the mask. You secure the elastic bands at the middle and head of the. This I've already told you how to wear the mask, and fix the mask to the face and below the chin, and you have to seal the mask. And the last step is to wear the gloves. Always use gloves and extend it to the gloves should cover the cuff of the gown, and same procedure may be required. Some procedures, like sometimes we may need to wear double gloves. Next. Again, doffing of PPE. When we are removing the PPE, again the order is reversed. First, you remove the gloves. If the outside of the gloves is contaminated, then you have to touch the outside with the opposite hand and peel it off, and place the removed glove in the gloved hand. Then slide the fingers of the ungloved hand under the remaining gloves. So these are actually steps which will have to be shown practically. And but just this is the reverse order. So first remove the gloves, then you remove your gown, and last to remove is the mask and respirator. And then all this should be discarded in the waste bin. These are the different ways of testing the respirator. Usually fit testing is to be done, but next. We do. There are some many quantitative respirator, and usually no one does it routinely. So we just do the next step. We do seal check. User seal check. Usually we do. So every time a respirator is worn, क्या करना है? It is a quick procedure, and it can be checked by positive pressure or negative pressure. So for positive pressure, you exhale while blocking the path. You have to see that the mask is tightly fitting. There is no air is not escaping from anywhere. Then exhale into the mask, and when you feel a slight pressure builds up in the respirator without any leakage, that means the test is successful. So this is for positive pressure. For negative pressure, again same thing. You ensure that it is tight, and you inhale, and while blocking. If a successful check is considered when the face it collapses under the neck. In this case, if you inhale, it should collapse, and when you exhale, it should expand. It should balloon up. So these are the way of checking the how to wear the mask. Then these are some equipments which we use in the labs, like biosafety cabinet. It is one of the most effective and widely used primary containment, and we use it while doing procedures like shaking, stirring, pipetting, opening of containers, and should be containment of biosafety cabinets is achieved by segregation of work, and there are high efficiency particulate air filters. जो HEPA filter होते हैं वो लगे होते हैं biosafety cabinets में. Air curtains are there, and there is controlled unidirectional airflow mechanisms inside the cabinet. And usually what we recommend for TB work is there are different classes of biosafety cabinets, class 1, class 2, class 3. What we use is class 2 A cabinet, type A2, and there is a ducting mechanism, all biosafety cabinets, and there should be a thimble ducting mechanism. So that is actually an engineering method. what are the functions for personal protection, product protection? We need to protect yourself, you need to protect your sample, and environmental protection. So these are the three purposes of the biological safety cabinet. Next. So this is the like inside the when we arrange our material inside the biosafety cabinet when we work. So this is the different areas. There's a clean area, there's a working area, and there's a right side is the contaminated area. So these are the three. We divide our working space into three areas, and we need to arrange our material. And we should never go from contaminated area to clean area. So our direction of flow should be from clean to contaminated area. So this is an autoclave. It is like I'm talking about the autoclave because ये हमें चाहिए होता है लैब में जो भी हमारा infectious material है उसको हमें sterilize करना है. For a low risk lab, we need autoclave is a low risk. It's there in a low risk lab also. It is mandatory, and any material which we need to discard has to be autoclave. Moderate risk laboratory. So it is required in all the laboratories. And labs require a secure place where we can place this autoclave. Okay, next. So these are again, I won't go to the different designs depending on the different design biosafety levels. Next. Sterilization methods. There are different methods of sterilization: physical, chemical, radiation. I think this is not to be done in this. Just last, I'll be telling the biomedical waste. So for different levels of laboratory, low risk laboratory. So all levels we need a yellow bin, red bin, blue bin, and black bin. So what all we need to discard in yellow bin is the TrueNAT chips, the coats, mask. The plastic material has to be discarded in the red, that is pipette tips, pipettes, TrueNAT cartridges, PCR tubes, and goes into the red bin. And the glass slides and metallic sharps need to go in a blue, and general waste is in the black. Next. Again, this is also like for a moderate risk laboratory. So depending on the materials which you are using, so they go into the respective bins. Next. And all 4 bins have to be present in all the labs. So just biosafety training is very important. Next. Emergency response, we should be prepared. Next. So we need to make a plan for this. Next. So it is a responsibility of the lab director and supervisor to ensure that all lab personnel have read and understood the emergency plan, and we have we have a fire drill, we have a any spill occurs, we have that drill and refresher trainings. Next. Then if any spill occurs, we need to have a spill kit in the lab. Spill kit contains all these things: phenol, mask, N95 mask. There's a jumpsuit, gown, shoe covers, gloves, bags. So these are the spill kit has to be present everywhere, anywhere in the lab whenever any spill occurs. So administrative policies also, this has already been talked about. They are important component, and in the lab also, I'm just reiterating it because lab also we should have the administrative controls are important, and they must be implemented and adhered to by all personnel working in the lab, and it's the duty of the lab supervisor to ensure this. Next. So airborne infection prevention also, we have to reduce measures to reduce airborne infection. This has to be applied in hospitals and includes, this is also covered, engineering and administrative controls have already been covered. Again, this is already covered. Next. So conclusion, so biosafety and airborne IPC is very important because it protects the workers and public health and the environment. We need to wear personal protective equipment, engineering controls, good lab practices and training are very essential. And last but not the least, compliance with guidelines ensures safety. So thank you.
Thank you, ma'am. Thank you for providing us with such a detailed and practical understanding of laboratory biosafety. We deeply appreciate your time and your expertise. Thank you, ma'am, once again. Now, all the topics from the agenda is covered. We have with us in our eco room our expert, Dr. Paul Hudson. Sir, I just wanted to extend my sincere gratitude for joining us in person here today. Thank you very much for joining us. It makes a real difference. Also from US.
It's a pleasure to be here. I have no slides to show, but just a short discussion.
Sir, let me introduce.
Oh, I'm sorry. I think you're done.
It's okay. Dr. Paul Arthur Jensen is an independent consultant in the areas of engineering controls, airborne infection prevention control, and laboratory biosafety. Sir is also co-founder and chief engineer of Final Approach and shares his expertise both domestically and internationally. Sir has extensive experience in sampling of analysis of bioaerosols, design and evaluation of ventilation systems, UVC systems, control of airborne microbacterium tuberculosis, and evaluation of respiratory equipment. Sir, would you like to add some constructive points in all the speakers they have told about that topic? You have something you want to? Happy to. We really wanted.
Okay. Well, first off, thank you for the invitation to join this and the great support that I've been given here at NITRE. And I thank the three speakers. And I just have a few general comments. The first is I'd like to follow what Sahu started this session with, but the last message for World TB Day, and that's commit, invest, and deliver. So you are here because you're committed, not mentally, but you're committed for infection prevention and control. What we need to do is we all need to be salesmen and saleswomen. What do I mean by that? We need to make sure that we can talk to our managers, talk to the public, and the public's important to include, about risk. And just because somebody has TB doesn't mean that they're of high risk. Maybe they've been under treatment and they're at the end of their treatment program. Maybe they have XDR TB and it was just diagnosed yesterday. Well, those are two different risk levels. And in the lab, we learned about different risk levels. Dr. Anita talked about different risk levels. Dr. Misha talked about different risk levels. So we have to make that message clear to our coworkers, to our subordinates, and to the management above us. And if we can do that by presenting data, can we show that there's higher risk of transmission in healthcare workers? Absolutely, we heard about that. But how do we get that message beyond just our workers? We can use data from other countries and say, okay, here are 3 studies from India, but you take a look, there are so many from Africa, there's so many from South America, there's so many from Southeast Asia. So it's a global issue that we need to address locally. And what was common between all 3 presentations? The importance of administrative controls, the importance of work practices. And when we talk about administrative controls, if the building is designed for natural ventilation, you have no mechanical ventilation. How well does it work with a closed window? Not very well. How well does it work with a curtain over the window? Not very well. So these are problems that we need to be able to solve. And when we talk about natural ventilation, the older buildings here in India are fabulous. They're designed for natural ventilation. If you have rain, the water's not going to go in the window, so they're more likely to be open. If you have a counseling room, we have heard recommendations, not just from WHO, but from other organizations too, about having open doors and open windows. Well, if you're counseling somebody on HIV, who maybe has TB, maybe not, do you want everybody in the corridor who's lined up with their nose to that door to hear those discussions? And I would say no. So we have to think about how can we enhance natural ventilation, but also providing patient-centered care. So these are issues that we have to resolve, commit to solving, and that to solve that, we need investment. So we need investment, not just moral support, but there's a financial investment too. The moral support is really support from other workers, your bosses, in implementing administrative controls and environmental controls and PPE. So if you have a policy for wearing respirators in a certain ward, a certain part of the lab. Do you have those respirators? Do they fit people? And we heard really quickly about fit testing. And do the workers know how to actually wear them? So there are many administrative policies that go along with PPE, that go along with environmental controls, and that also go along with a long list of policies and practices and SOPs within the facility. So then we talk about investment with money. How do we influence to get funding to implement change? Well, the best way to get funding to implement change is to show commitment and to show at least some level of effort of implementing and at least some level of data to show that, okay, we've reduced the transmission in our facility lower than the average healthcare worker, but still higher than the general population. So with data, we can help convince people that, if we save one healthcare worker from being out of work for a long period of time, there's a cost benefit there. So if we can show some kind of return on investment, then we can get some kind of commitment for investment. And the last thing is deliver. What does deliver mean? We heard a little bit from Dr. Sahu about that, but deliver is we deliver, in this case, NITRD, a safe environment for the patient, for the healthcare worker, and for all the visitors. By visitors, I'm talking about family. What about people that come in here from outside to do maintenance? We need to provide a safe environment for them. So if somebody's coming in from outside, I'm out of time, but let me just finish this one thought. See, I set the timer so I'd be in. So if we can, educate people, the general public as well as the healthcare worker and patient, we educate the folks coming into our facility that, hey, if you're going to work on, let's say, a ventilation system, an exhaust ventilation system, because the fan stopped working. It just happens to be in the TB ward, that MDR TB ward. Do you want them to just walk in there? No, you have to explain to them what the risk is and how you're protecting them from that risk. So again, just in summary, we have to, focus our thoughts about, the commitment, the investment, and the delivery of, good public health messages as well. So thank you.
Thank you, sir, for incorporating your expertise. We loved it. Now, before moving to the question answer session, we have our chief guest DDT TB here. Ma'am, we are truly honored to have with us today. You here, your vision and commitment continues to motivate healthcare professionals, especially nurses, to work tirelessly towards the goal of a TB-free India. Ma'am, I request you to please say a few inspiring words to our participants here. Ma'am, can you hear us? Ma'am, are we audible? Maybe some technical error. We'll reach it back, ma'am, if you're there. Now.
Good afternoon.
Yes, she'll join.
Good afternoon, everyone. Good afternoon. Thank you, Dr. Manpreet Bhalla, Director NITRD, Dr. Neeta Singla, and Dr. Paul. It's an honor to meet you virtually. And let me congratulate Dr. Kansal for organizing a phenomenal webinar. I hope it is useful for the participants. And I'm not really able to see how many participants have joined.
It's 320 nearby.
So we acknowledge the work of Dr. Paul, the initial work and the work he continues. Dr. Volchenkov was also joined, and I think it's an honor to have international experts on this webinar. And I think you very deftly, all the participants, all the experts have actually covered all the topics in the field of airborne infection control and what is the options we have. And let me now allude to my work during my professor tenure at All India Institute of Medical Sciences. That's when Dr. Paul's team had also honored us by visiting us when the initial the UBGIs were put in NITRD. So under the so we were actually trying to, you know, in old buildings when we're not able to bring them down, we have the binding of, somehow adjusting, whether we want to put in UBGIs or we want to ensure air changes. So those have been a few challenges in working with old buildings, but with new buildings, it is always best when we can have the recommended tools for taking care of the air inside OPDs or in bed wards, or all these wherever we need patient care is being given, whether it's a crowded OPD like was shown by during the presentation, or it is MDR-TB wards where we need to ensure. In new buildings, what has come our way now is induct UBGIs, which we were able to put in place in our new building, a new OPD building in AIIMS, New Delhi. And same we have been discussing with Director NITRD and her team that when the new building comes up at NITRD, we'll be able to suggest induct UBGIs to be put in place, which will ensure air changes and will also ensure purifying the or disinfecting the air, that's the better word, including air changes while it flows through the air handling units. Under the program, what we have done, we have taken a major initiative. My team, led by Dr. Sanjay Mattu and supported by a fine team, we've had trainings all across the country. We have ensured that people are now well aware of AIC recommendations, how they should redesign or remodify their, the wards, the labs, the OPDs. All of these need due care for AIC, for the sake of our staff, for the sake of enabling us in dealing with large volumes of patients or patient samples. This training having been done all across, the trainings have been redone, reiterating the facts, and we've covered the whole country. We are now at the point where we are in the process of supplying disinfecting or disinfecting units. In fact, I remember there was a time when we would look up to Canada or the US to import UBGI units, but now we have within the country manufacturing of units. In fact, one of the big manufacturers, Philips, is also supplying covered UBGIs, which includes air suction as well. So this moves the air within a room. So currently, we are in the process of enabling our units across the country under the program with these units. Also, the airborne infection control guideline was laid down by the program early on, that is in 2010. We are revising that, and soon there'll be a new module. The revised guidelines will be available soon from the program. And like I said, these webinars can be very helpful in reiterating facts, adding on new guidelines as they come in for the sake of the healthcare workers' safety. We have also gone on to create modules which are available on smartphones for our patients to ensure no airborne infection inside their households. So those guidelines are also in place and will soon be actively disseminated to all patients to take care of their families, including discarding of sputum and those details, including cough etiquette and so on and so forth, especially in the initial few days of initiating the ATT. So that is the kind of work the program has been doing. We would actually look forward to inputs from the international experts if they would like to guide us further. And thank you again for having me address the gathering. And I was unable to hear most of the meeting. I was in parallel 2 meetings, so couldn't really. But then we are always open to suggestions and ideas. So thank you again, Dr. Manpreet. Yeah.
Thank you. Thank you, ma'am.
Thank you.
Thank you for all the information you have shared. Your words have set a strong foundation for this webinar. We deeply appreciate your time and your valuable contribution. Now, moving on to the question answer session. Dr. Neeta Singla is also with us. Ma'am, would you like to incorporate anything from your side?
Thank you, Shiva, and I congratulate e-NEETI, our director, Dr. Manpreet, and ET for conducting such a beautiful workshop where everybody has got an opportunity to learn. I myself have learned so many things in today's session. So I would just like to say that there's a lot of things happening under the program, and as our DDG just informed that the new guidelines are coming, and everybody has already been trained on these guidelines. So from administrative point of view, we need to have good hospital infection control committees who should be active in looking out for what measures can be taken administratively and engineering things that need to be done. We have to have very active infection control officers and infection control nurses, who should go around and inform the administration what really needs to be done. And of course, at our own level, we have to have a change in attitude. We have the mask, but sometimes they are on our hands or they are in the neck, but they are not on our nose. We need to frequently wash our hands. Whenever you're doing a procedure, please wear a goggle wherever required. So that change in attitude has to happen, and which will happen with repeated trainings, undergoing trainings and hearing such things. So I really congratulate everybody and thank you all for this information that we have got today.
Thank you, ma'am. Thank you, especially for the words, for the nice words for e-NEETI. Thank you. Now we are moving to question answer session. Then feel free to ask questions out loud, or if you are hesitant to ask, please write in the chat box. I could see many questions are already there, so we will share. You can ask questions. Chat box first. We are reaching to the questions in the chat box. Please mention the name of the instrument which you have showed me.
Yeah. This is it's made by a company called ARANET, Aranet. And this is the Aranet 4, which tells us temperature, humidity, and CO2. And not because I was talking, but the room CO2 level went from 770 when we started, and it's now 1,850. So it's more than double. So why is that? That's because there's no fresh air coming in this room. The door is closed, there are no windows, there's a ceiling fan, but that does nothing.
The next question is, ma'am, we have to look wind direction also, exhaust direction too. So that is not a question, I think that's an information.
Very good comment.
It's a comment. Okay, next is, how can I determine in DMC that unidirectional flow of air, unidirectional flow of air is happening?
Would you like to answer that?
Sure. There are many ways you can do that. One is you could use like incense, but put your hand over top of it so it cools. You could use some kind of...
use some agarbatti.
Yeah.
अगरबत्ती अगर आप जला के उसको देखोगे कि वो किस डायरेक्शन में जा रहा है, तो आपको पता चल जाएगा कि जिस डायरेक्शन में वो धुआं जा रहा है कि ये हवा उस तरफ मूव कर रही है. दिस इज द सिंपलेस्ट वे. और अगरबत्ती टिश्यू पेपर का छोटा सा वो भी कर सकते हैं, बट अगरबत्ती यूजुअली पीपल यूज इट. That is incense sticks now that we use to our God,
right?
Worship our God. So that is part of our this thing.
And the other thing I've done is I've taken a paper towel, light it, blow it out,
Yeah.
and then you get spoke to. So it's just any, or you can take, well, I don't advise it, but there's one place that took baby powder in a can, just puffed it, and saw which way it moved.
Okay.
So I think your question is clear.
Just one comment. Hello.
Yes,
Yes, sir. Yes, sir.
Yeah, अगरबत्ती जलाते वक्त सिर्फ इतना ध्यान रखना, we just need to keep this in mind that many a times in the wards we have this
Oxygen. Yes, sir. Yes, sir. Of course, that has to be taken care.
अब बाहर से जला के और फिर अंदर चेक करें.
जी.
Yes.
Thank you, sir.
Thank you, sir. Thank you. The next is it possible in peripheral or rural hospital? So that has been answered already. Is there any chance of adverse effects due to UV exposure if it is placed in the patient's area?
That's excellent question.
Yeah. Please, Dr. Paul will answer.
And you may not remember it, but there's a little graph before that showed wavelength versus effectiveness. And there's this peak around 260. And then there are a couple other lines. They weren't identified verbally, but one was skin cancer, one was erythema, which is just reddening of the skin, and the other was photokeratitis. What we need to do is stop using the term UV, because UV includes UVA, UVB, UVC. For UVC, which includes the germicidal wavelength, there are two adverse health effects. One is a photokeratitis, and the other is skin. Now, if you have a well-designed fixture installed properly and maintained properly, you'll have nearly zero UVC in the occupied space. If you do accidentally, and again, I don't recommend it, climb a ladder and stare inside the fixture, and you have glasses on, you'll look like a raccoon because your skin will become red, but your eyes will be protected because that UV is not very penetrating. And that reddening of the skin in a day or two will be gone. It's different than sunburn. And even if you had photokeratitis, it would resolve itself in 24 to 48 hours. But that's why we're actually doing the testing of UV units this week and part of next week as part of a FIND project. Over.
Yeah. Next question. Does fogging or fumigation of hospital ward units have any advantage in TB prevention? Yes.
Okay. The short answer is maybe. Is it very useful? I would say, sort of on the, not absolute no, but on the negative side. And the reason I say that is the fumigation of let's say a patient ward is good for killing what's in the air, killing what's on surfaces, if you get that chemical in a high enough concentration. But in a big ward, you're going to have leaky windows, so you're actually going to have to carefully figure out the dose. Now, in a laboratory, I'll let you answer that.
Yeah.
Any chances of false positive? Sorry, lab. I thought she maybe asked to answer the next question. Sorry.
Yeah. So in the laboratory, actually, also fumigation. Usually, where we are using the biosafety cabinets, we just clean the biosafety cabinet, and it is the process is done inside that. But in a lab, recently we have read that fumigation is not recommended, or if you are doing fumigation, should not be done with formaldehyde. We should use some other chemicals which are not very toxic to the eyes and corrosive. So that can be done.
Okay, thank you. Any chances of false positive results since everyone are using same place for sample collection? For the lab. Okay. It's for the lab, I think so. Yeah.
So
can you just show the question?
Can there be cross contamination of samples?
Yes. So see, as I told you, if we follow the good laboratory practices, then we can ensure that there should be no cross contamination. And between handling between one sample and the other, we follow the SOPs. And like in our lab, we are handling so many samples per day but most of the times, because our technicians are trained, there is usually very less chances. We cannot say that is zero chances, but there are very minimal chances of cross-contamination if we take the necessary precautions.
You suggest IGRA for lab staff working in CDST lab, as a chance of exposure to them has been high. Please, Opan.
So both the two questions, the IGRA and the screening, is true for everybody, whether you are in the lab or outside the lab. The annual screening is mandatory kind of for everybody. Every year, everybody should be screened for tuberculosis, especially if you are working in TB hospitals like ours.
Okay, from
occupational, I would like to come in here. It's important to screen annually, like very well reiterated by Dr. Neeta Singla. So screening for active TB, that is mandatory for all healthcare staff, whether it is lab staff or the other healthcare staff. The question was for IGRA. Now, IGRA is not the only test available to us. We have the tuberculin skin test. We have the SciTB test, which has the same antigens as that has been validated by ICMR, and the program is in fact supplying that free of cost to all the program. In fact, it's available with the DTO. So when you would like to screen for infection, this is a free test available under the program, can be used. The recommendation to initiate TPT, again, Dr. Neeta can add to what I'm saying, but the most important thing is to rule out active TB, because the healthcare workers are at higher risk, whether they are in the OPD or wards or in the lab. We must offer them annual screening, rule out active TB, and then only consider TB preventive treatment, for which screening for TB infection can be done using the test that we recommended. IGRA is at least 10 times more expensive than SciTB. SciTB follows the principle of tuberculin skin test. It's an intradermal test and uses 2 antigens as have been used in the IGRA. So that is the recommendation of the program. And annual screening to rule out active TB is a must for all healthcare workers. Thank you.
Thank you, ma'am. The next question is from occupational health point of view. Should we make policy on screening lab staff for TB disease or TB infection? Which one is to be prioritized?
So this is already covered.
Do we need to switch off blower in a ward equipped with AC? This is under engineering. Yeah. Dr. Mishra is there.
Yeah. Can I answer? Yeah.
Yes, sir. Yes, sir.
See, AC is usually cost efficient and energy efficient in a closed room. Okay, so in a closed room, AC will work, but there the air exchanges are not going to occur. So if you want to install ventilation system in an AC room, then there one model is there that you have to give a fresh supply in and supply of exhaust air out, but that will not be energy efficient. We have something called the HVAC systems that can be installed.
Okay, sir. Thank you. Next question is, madam, can we perform midget open liquid positive samples in BSc class 2 A2 and identification with Maldi-Toff TOFs? Mia can prepare in BSc class 2 A2. It is safe for laboratory technician. Is it safe for laboratory
Yes,
technician?
I've already covered this. So whenever we are doing liquid culture handling, we need to do it in a biosafety cabinet. And usually what is recommended for TB work is class 2 A2, I told you earlier. And then we can do the Maldi-Toff also. That is another test which can be done for diagnosing.
So, Dr. Manpreet, I think we would recommend 2B2 for handling liquid cultures and not 2A2. A2 has 40% recirculation while B2 has 100% exhaust. So if possible, B2. And when handling a liquid culture, you should have a TB containment facility as has been laid down under the program. We have more than 80 culture DST labs. So all the labs which can offer DST can also do liquid culture handling for further processing.
Thank you. Any references of companies, consultants for constructing a TB laboratory?
Only the engineering can.
I mean,
It would not be ideal for anybody to recommend such company.
It's not ideal in this.
It has to be, you have to look for the best company available.
Okay. Can TPT be initiated for healthcare workers after screening for latent TB?
Dr. Neeta, I think can answer.
Yes, we should do a CITB test. If the CITB test is positive, we have to rule out active TB by other measures. And if there is no active TB, we should give the TB preventive. And it is freely available in all the district centers and all the microscopy centers across the country.
So I'll reiterate, ruling out active TB is the most important. TB infection comes in much later. An X-ray followed by a NAT, as is being done under the campaign. It's very, very important to rule out active TB, including signs and symptoms of extrapulmonary TB, if any. So all these have to be in place before you think of TB infection.
Thank you for bringing all the questions here. I think there is no more questions in the chat box. So we are coming closer to the end. As we come to the end of this webinar, I would like to extend my sincere gratitude to all our esteemed speakers, experts, and participants for your valuable contribution. Your time and effort and engagement have made this session truly engaging. Now, I request, for concluding the session, the webinar, I request Marty Vanderwalt, Vice Chair ETI Consultant, TB, HIV, Epidemiology and Pandemic Preparedness, South Africa. Kindly give closing remarks. Ma'am, can you hear us?
Yes, thank you. I can hear you. Can you see my video?
Not yet. No.
Can you hear me?
Yes. Yes, we can hear you.
On my side, it shows that the video is going. Yes. But not on your side.
Blank screen.
Blank.
Yeah. Select the camera, same, pardon, mirror my video. Oh. Now this is the first time that this has happened. Let's hope the video comes on, but I also do not want to put an abrupt stop to this very wonderful webinar while we try to sort out the IT issues.
Just continue and talk, please.
Yes, I think so.
We'll manage with the DP.
Yes, thank you so very much. I will continue, and it is an absolute pleasure for me from the Southern Hemisphere to be able to do the thanks. Thank you in the closing remarks. This webinar on nurses' efforts to eliminate TB in India has really been very, very informative and very topical. The presenters and then also Dr. Singh has all spoken to what we can do as a joint effort in the commitment to end TB through commitment, investment, and delivery. The webinar started with Dr. So from the Stop TB Partnerships, who reflected on where we are in terms of TB control and what we want to achieve annually through the MTB slogans for World TB Day. And to say again, the slogans for this year is commitment, investment, and delivery. And today we've seen very, very many best practices from India on how India has been able to fight TB through this. Then Dr. Grigory Volkenchev introduced the ETTI Stop TB Working Group, which is a knowledge hub. And we also enjoy the knowledge and experience of 3 Indian committee members there. Then we went over to the administrative controls presentation by Dr. Anita Kansal, who showed that sustained learning and training led to increased knowledge and awareness amongst healthcare workers, nurses, and everyone about what TB is and how it can be implemented. Certainly shows that the National Strategic Plan of the National TB Elimination Program of India, that the infection control plan, it shows what a good plan it is, and importance of empowering nurses to implement the plan. The next presentation was by Dr. Mishra, who spoke about tuberculosis in healthcare workers. That was really a wake-up call to all of us when we've realized that our healthcare workers, who are those that need to cure our patients, are actually at a very high risk to contract the same disease that they want to treat in their place of work. Now, this is a very concerning thought, and to know that while we want to end TB, there's also a global shortage in healthcare workers. While healthcare workers is essential to achieve the goal of eliminating of TB. Dr. Mishra also mentioned that laboratory workers are also a high risk group in terms of TB. And then the next presentation by Dr. Bala, who is head of the microbiology. I enjoyed particularly very well because I also have a background in microbiology, but it was again a sobering thought for us to know that we should not forget biosafety principles in laboratories. Laboratories are not separate from what's happening in our health facilities. So we should not forget laboratories when we look at infection prevention and control practices, or that we should test laboratory workers also quite often and regularly, just as we would do for our frontline healthcare workers. So those three presentations and the discussions brought us then to the end of this webinar. Now, part of the World TB Day and the series of themes of Yes, We Can is also a call for optimism, accountability, and resolve. And India has certainly shown over many years that it is a best example of a country that has a dedicated journey towards TB elimination and has been recognized globally for its efforts to decline TB in India and then globally, which is over twice the global decline. So I want to urge everyone to leave today with optimism. And what Dr. Singh has also in her presentation showed that there is real commitment from the National TB Elimination Program to end TB. So thank you very much. And yes, we can end TB.
Thank you, ma'am. Thank you, and thank you all the participants. Give your feedback. Feel free to connect with us. Stay safe, and we look forward to seeing you in our future webinars. Goodbye and take care. Sorry, before going, please give your feedback. Send your feedbacks in the link. And surely there was one question whether we'll send you the recorded version of this webinar. Yeah, sure, we'll be sending the recorded version through a link within 2 days. So kindly send your feedback, please. We'll keep it Please be keeping this session open for 2 more minutes so that you can send your feedback.
Thank you.
Thank you.